Combien tu as reçu l'invitation?
Oui, ben c'est à partir de ça que je me suis connectée.
Non, non, maintenant. Code.
Le code et le... Oui, oui, je les ai reçus, mais ils étaient dans le premier mail.
Non.
Si, si.
C'est bon, c'est bon. C'est bon, tu as reçu le...
Oui. Mais je n'ai pas eu besoin, en fait.
Oui, pas besoin. En fait, pas besoin.
Mettre l'ordinateur là-bas. Oui, ben c'est à partir de ça que je me suis connectée.
Non, non, maintenant.
Le code et le... Oui, oui, je les ai reçus, mais ils étaient dans le premier mail.
Ah, il y a un problème. Non, non, non.
Si, si.
C'est bon, c'est bon. Alors, je partage avec vous le lien YouTube. Si vous voulez partager ça avec vos collègues qui veulent assister par YouTube sans s'afficher sur le Zoom, suivre. Voilà. Donc,
Pardon.
Alors, en attendant, je vous invite à chercher sur App Store et sur Apple Store aussi, Upsurgeon. Alors, vous aurez deux applications, Upsurgeon Neurosurgery et puis Head Atlas. Alors, je vous invite à les télécharger, à les installer. On aura besoin de notes pour le workshop. Bien sûr, c'est l'occasion de s'habituer à cette application d'ici demain pour l'utiliser au cours du workshop. Voilà, donc, comme ça a été déjà précisé sur l'email, je vous invite au démarrage de cette réunion, disons, confraternelle et amicale, de faire marcher vos caméras. Comme ça, on a l'impression qu'on est dans une salle de conférence sans avoir à faire un déplacement parfois pénible pour assister à un cours. Et donc, ça encourage encore plus de poser des questions et de profiter de la présence de nos maîtres pour poser des questions, surtout sur tout ce qui est technique, tout ce qui est piège technique, difficultés techniques, des questions auxquelles on n'a pas de réponse, ou bien qu'on vient de se rendre compte qu'il faut poser cette question pour une finalité que celui qui la pose peut la définir. Donc maintenant, en attente du professeur Napadi et des autres conférenciers pour démarrer, je vous souhaite encore une fois la bienvenue et moins de soucis pour télécharger l'application. Il suffit de me le signaler et vous aurez des codes d'utilisation gratuits demain, Inch'Allah. Hi, Federico. How are you?
Hey, Fad. I'm fine.
Why? Alors, prière de faire attention au micro et pour ne pas troubler le déroulement des conférences. Bonjour, professeur Esbenali.
Bonjour Fed, comment vas-tu? Ça va?
Très bien.
Très bien. Bonjour toi.
Bonjour Saïd Benali, vous allez bien?
Alhamdulillah, Madame Bougane, ça va? Alhamdulillah.
Alhamdulillah.
We have with us Federico, the neurosurgeon genius who creates Upsurgeon and this wonderful staff. Our colleagues who will be there tomorrow will enjoy different approach. What? It is two parts. Okay.
Good morning, everyone.
Good morning.
Federico, we are waiting, and are you ready? maybe we will start in in 2 minutes.
Yeah.
We're waiting Professor Najira ready. Maybe she has a phone call so she will join us in a few seconds.
How are you, Professor Nicolosi?
Hey, how are you? I'm fine. How
Thank
are
you. Thank you. Thank you very much.
Nice to be here with you guys.
Yeah, thank you.
So just to understand, Fad, the hands-on is tomorrow, right?
Yes, hands-on tomorrow. We split the program. Last time it was too long.
Yes.
So we split the program. We have.
So all the people that I see connected here will be part of the hands-on.
Yeah.
Is this correct?
Yes. 40 participants.
Wow.
Yeah.
Huge. Fantastic.
Yes. I'm
Very nice.
happy about that. We are using what you have sent and what we have for our lab in the same time.
Yes, fantastic.
It makes a lot of stations and
yes, fantastic. Because I remember that we did a course with your lab, and now we have another set of simulators and everything, new stuff, etc. Did you have all the information from our team? No, how to?
I will ask you some question about the new stuff that you will launch. You will announce tomorrow. Micro.
Yeah.
I think that we will be. It's the announcement day today, tomorrow, about the micro.
We can have Marco, the engineer behind the research.
Yeah.
This
it's
kind of
some devices, how to put everything.
Yeah, it's very easy.
It's very easy, I think. Yeah, and also for the visors.
Yes.
I'm not comfortable with that.
No one is comfortable with it.
Yeah.
Virtual reality is fantastic. We say we need to do that because this is progress, but in general we are surgeons. We want to move our hands, we want to touch things.
Exactly.
We support very much virtual reality, but at the end of the day, also the youngest generation say, okay, but where is the blood? It's normal.
It's normal, yeah.
This is what
we need to put blood.
Yeah.
Okay.
Whenever you like. Is my turn now?
I will start. I'm waiting for Professor Betty to give a few words, but she always told me to not be late on the program, so maybe we will start. Welcome everybody. Welcome everyone. Waiting Professor Betty to join us. I will just say a few words. So I'm trying to share my slides. So welcome. It's not the first workshop here in Morocco. It's the second edition, and I'm glad to have again this technology in Morocco. I want to thank first all the faculty, local and international faculty, to join us. Also, I want to thank Absurgeon, the CEO of Absurgeon, Federico Nicolosi, professor in Milan of neurosurgery, and also all supporters. I will not say sponsor, it's supporter and host of this advancement in simulating neurosurgery in our country. The Sheikh Zayed Foundation, our university, Abu Qasim University, and Sheikh Zayed Hospital, and also all university departments who are supporting each advancement around in Morocco and Africa. Well, sorry, I'm trying to share my slides, and I am the host, and I can't share my slides. This is technology. This is always the problem with technology. Okay, I'm trying. So just to give you a brief Okay. Sorry. That's this again. It's possible now. Good. Did you see my slides? So we are together today for this second school-based and vascular neurosurgery workshop, the global training project 2022. We start this global training project in Morocco, and we are happy and honored to be the first to start this and to announce the creation of the officially of the neurosurgical lab at the Simulation Center of our university. So I don't know if you see my slides. I don't know. Not sure. Okay. Okay. Well, I want to thank Professor Abedi. She's the pioneer of to develop this field. I am Fatah Kawi, and I'm honored to take part of this experience. Well, we have this workshop in two parts: theoretical and practical part. Theoretical with amazing faculty around the world. It's not our first experience. Last year we had this first experience with the conference about simulation, and also with a lot of topics and one day hands-on on cadaver-free workshop with 30 participants. Here our previous experience, and it was just amazing to have okay, today we will have this second advocacy symposium or workshop with the second experience with Federico and Absurge. We have amazing faculty, Professor Fadi Chalvet, Professor Marco Senzato, Professor Kipar, also many other local faculties, Professor Wahebi, head of department in the specialité, Professor Esbeneli, department in Marrakech, Professor Esbeneli in Casablanca, Major Boujouena, neurosurgeon and endovascular surgeon, and also anatomist in Morocco. So Bougrine, she's pioneer of this workshop also in Morocco, and who is representing and acting actively at the Moroccan Society of Neurosurgery. So these are our local faculty, and as I said, we have two parts. The first part is today, and the second part is at our simulation lab at the university. So the first part of the program today is with the mini talks about different approaches, different tips, different tricks, and I invite you to ask questions to all faculty. And the second part is about mental training, training, and mental training. We will have Federico Nicolosi, who will say more about this. We will see all these details tomorrow. Absorption helps a lot, and also our university to provide boxes, these devices, and also university provide all needed material and the foundation for this workshop, thanks to the foundation of Sheikh Zayed. Well, we will have mini station tomorrow with for mental training, training, and manual training, and you can use the software. I asked you already, I sent to you the name of the software to download it. You will enjoy look into the different anatomy. Also, this is the training associate what you can see with virtual reality and the boxes. And finally, you will have the opportunity to look for these elements directly on the boxes for the doing some craniotomy, during opening, and making sutures, also exploring inside, exploring different approaches, pteronal, like closing temporal, and the hemispheric, also transphemoidal. You will have a lot of fun doing that and a lot of knowledge. You will have also the local faculty near to you. They will be happy to show you every structure to show you how to do techniques and also to answer your question. And you are welcome to be interactive during this workshop and enjoy your day with us. So also we have the opportunity to use for the first time the micro for bypass and dural structure, amazing the achievements of the absorption and doing some sutures. Also, we have the possibility to have to do brain tumor station and make removal of glioma. And you can in each element you will have the possibility to see what structure that can you meet during each approach. So also there is visors, these virtual reality devices, new development of absorption. So welcome again, and thanks to everyone, to the faculty and to the participants to be part of this workshop. Thank you so much. Federico, I think it's your turn now to give a few words to our colleagues.
Yes, do you hear me?
Yeah.
Okay.
So let me introduce Federico. Federico is the CEO of Absorption and also associate professor in Milan, University of Milan. He is the one who were able to make neurosurgeons, anatomists, engineer, and artists to be in the same table and create what is now called absorption devices. The floor is yours, today.
Thank you very much for this kind introduction. Let me share my screen. Do you see my screen?
Mm-hmm.
Probably you see the wrong screen.
No, we just go to the screen and
yeah, I need to switch.
Switch. Yeah, switch.
Do you see my screen now?
Mm-hmm.
Can you say to me if you see the correct screen? I'm in the presentation.
No, please switch. Cambio, I think.
Okay.
Okay, now it's
perfect. So thank you very much, guys. Sorry for this inconvenience. I have three screens in front of me. So thank you for the introduction. I am very happy and honored to be here with you. I am a colleague of you. I am a neurosurgeon, and as Fad said, my adventure has been to merge two lives, which is, I mean, neurosurgery life with all the tough challenges that we do and know every day, and also trying to enter in the technology to impact in some way in the tradition, in the way we train people and we train ourselves, not to replace the tradition, because the tradition is absolutely the base of everything, but to help the tradition, to support the tradition of training. So what we did In 2017 was to create Upsurgeon, and in 2021, for the first time, we did the first courses in this program, Global Training Program 2021. With FAD, we have been together organizing the very first courses, and the first in Morocco last year. Let me say that Morocco has been the first place with a lab for residents all over the African continent. So, I mean, it's a very important place. And so I declare my connection with Upsurgeon. Talking about why we did all these things and why we invented these technologies, we know that neurosurgery requires a series of non-natural skills, which are mental and manual skills. And we know that these skills can be enhanced in some way. And all of us, we know that, for example, practicing sports, practicing music, we train ourselves every day or almost every day. And we should use the same concept also for surgery. I mean, we should improve our skills with the exercise. The small problem in surgery is that when we talk about exercise in surgery, we are saying that we should do repetitions of something. So it means that we should be always in the OR or always in a cadaver lab. So this is the only way to practice and to repeat. The issue is that we cannot always we are not always allowed, obviously, to do our errors on a real patient, and we always have limits with cadavers given the accessibility of a cadaver lab and the costs. So what we know today is that to train people, to train our residents, we try to give them access to the OR, the green. If the green points represent, let's say, the random activities that we do in the OR, it means that any resident of a school has different chances. So if you take 10 residents of the same school, at the end of their cycle, they will be different, one from another, because they have different days, different masters, different periods in different hospitals. So the reality is, and I say this on myself, that at the end of my career as a resident, I was prepared to 30–40% of the topics of neurosurgery. This is the reality, because we train in this way. So what we want to do is not to replace this, we want to complete this with additional dots, with additional moments, with additional exposures to other moments, I mean simulation. And please consider this. Someone could say, so we are saying that tradition is not good? Absolutely not. What I am saying that if we talk about simulation and if we mention Ghazi Yazerji, you should know and you should remember that Yazerji did many hours of simulation in his career on rats. So when I say simulation, I do not refer only to technology. I do refer to any way to train your skills, also on animal models, also drilling a egg, everything. What we have done in Upsurgeon has been to connect neurosurgeons, people from science, so our people, with engineers, digital artists, developers. Believe me, it's very difficult for a neurosurgeon to talk with a 3D artist, with a developer, with an engineer, to create an optic nerve with that specific position, with that specific consistency. This is very challenging. So to do that, we needed to create a language. We needed to create a language to connect science with this kind of professionals. So we created a team made of a scientific team and a development team, and we created this language to bring literature to realistic simulation and very impactful simulation. And we started publishing this kind of processes. I give you an example. This is a borehole. It's something easy, it's something simple. I remember my first borehole. When I was a resident, my first year of residency, my first day of residency, another resident gave to me the high-speed drill and said, okay, try it. And I did a terrible error. I destroyed a part of the skin. There was a part of the muscle. I did my error on a patient with my first borehole. So this is an example. But imagine if for the first time a resident has the possibility to do 15 barrels in one session, in one place, in one day, the first time. This is obviously multiply this example to anything, and you will have the real training that we want to achieve, a way to reproduce this kind of exercises, not replacing a cadaver. In this case, we are replacing a piece of skull, which is disposable, and we can use this many times. And this is what you are going to use tomorrow. many disposable pieces, many disposable parts. So you know the impact of this problem. In many countries, neurosurgery doesn't exist. In many other countries where neurosurgery exists, there are a lot of claims. So the problem of quality and quantity of education in neurosurgery is critical. So this is a real humanitarian emergency, because in many countries, there's no covering of healthcare for neurosurgical diseases. We are working in many senses with this research group, and obviously we are trying to, let's say, to take concepts from other disciplines. For example, this is an example, and other disciplines like the defense in the US, I mean, programs to influence the attitude, influence the psychomotor automatisms. Are we able to create a new automatism in a person, in a surgeon, in order that if you have a complication, if you have a bleeding, you are not required to think, you should go automatically to take a cotton oil, to do specific movements, to be instinctively able to manage the moment. So this is what we're trying to do, this kind of automatism. This is what we do, and this is what you are going to see tomorrow. This is the kind of the example of detail. And of course, if we see all these structures, you know better than me what we are looking. You imagine the oculomotor nerve. You say to an engineer, we need a super soft oculomotor nerve behind the carotid with this specific perspective. We need capillaries on the optic nerve, etc. We need the CSF. I mean, it's very complicated. We developed this in a few months thanks to a language. So this is what we are going to do tomorrow. This is an example of aneurysms, but you will see other examples in your practice. The key word is enjoy. Do your errors, try to stress your perspective, try to go deeper, try to understand how to see the tip of basilar through eptorional, try to clip an aneurysm in that position, try to do all the errors you wouldn't do on a real patient. So today, this technology spread out around the globe, and we are working with many countries around the globe. We are giving to many trainees the possibility, the opportunity to get in connection with this technology. And of course, all these technologies need to be validated, because otherwise a technology without validation is just simply a toy. So we are working with science and with scientific method, and you would find a lot of literature around what we are doing and what we are trying to demonstrate. The most important problem, this is interesting, this in August I wanted to mention, because we have been mentioned as part of the history, let's say the recent history of this new era of training from these authors. And this is our initial validation. We started with several universities around the globe, like Harvard, to do pilot studies to demonstrate scientifically that if you take a number of residents for 6 weeks and you put them training on specific exercises like a gym, you can demonstrate the improvement. You can measure the skills the first day and the last day, and you will have a result. And the preliminary result has been very motivating and inspiring. We started demonstrating that the learning curve improved, the quality of the training improved. So this is what we are trying to do. And I will finish with a video to show you and to present to you the words and the impressions of other colleagues around the globe that are using this methodology. And my last message is, independently by the methodology that you use, we should invest our time as educators to create a generation which is oriented to the self-improvement, to the daily exercise, and to the quality. We cannot randomly train ourselves and our residents. We should create this kind of environment and this kind of discipline. So I finish with this video.
For me, this is a real revolution in training that open up new horizons.
I really feel like the residents and fellows and medical students all get so much more out of using this system.
I was very impressed, actually. All of the learners were very impressed with the amount of detail with the anatomy.
The virtual reality and the app is very tremendous for the residents. It's something that they can go back to, and we thought was very useful.
Just reinforces the anatomy and surgical approaches in 3 ways, and 3 times repetition which really just reinforces the concepts of the structural anatomy and the approaches for the students in a way that I've never seen before.
Brain boxes are changing the way education works.
I've had the wonderful opportunity of talking to some of its key team members and their vision, and I've been truly left with a great sense of hope and inspiration from what they're trying to do.
I think this is an amazing way for residents to get hands-on experience and devote a lot more hours to this than they would normally be able to.
This would be very interesting also in a lower developed country where the possibility to reach a lab which is so simple, so you can put it in a box and without requiring the setting that whatever lab will need is very interesting.
Education is now possible anytime, anywhere, and also for everybody.
So I finish here, and I thank you very much for inviting me for this introduction, and I will follow the course, and for anything me and my team, we are available for anything you may need.
Thank you so much, Federico. Really wonderful speech and wonderful, inspiring video. Absorption on Federico showed that we can move further if we think out of the box. So let's move. The next speaker is Professor Kipark. He will not be with us. He just sent a video because he's traveling and with the poor connection in Asia. So I will share his talk, and then Professor Wahabi apologizes also. He sent his video because he is sick, and let's go for the speech of. I'm trying to share my screen, so let's say that. So Professor Kipark, he's chair of the WFN's Global Neurosurgery Committee and the Global Neurosurgery Initiative, and he is professor at Harvard Medical School and well-known and active neurosurgeon for global neurosurgery. Did you see my screen? Okay, so his talk is using technology and innovation to accelerate neurosurgery capacity building in low and middle income countries, a global neurosurgery perspective. There is a wonderful talk about what we need for the future in neurosurgery in our countries. Go ahead.
Well, hello, everyone. I'm delighted to be part of this course. Thank you, Nadia and Federico, for your kind invitation. And I always have to give a...
Do you have the audio? I don't think so. Excuse me, do you have the audio?
Yeah, we had the audio, Fad. I had the audio.
Okay.
Fad, who is who never. Well, hello everyone. I'm delighted to be part of this course. Thank you, Nadia and Federico, for your.
You have the audio?
Yes, I hear.
Sorry, do you have the audio?
I hear Keeper. Fad, do you hear me?
Not good. Okay. This video is online also, so I will try.
Of how do we better deliver neuro.
You have the audio?
Well, hello everyone. I'm delighted to be part of this course. Thank you, Nadia and Federico, for your kind invitation.
Excuse me, do you have the audio?
Yes, we have it.
And I always have to give a nod to Fad, who is who never ceases to amaze me and how he's able to put together these conferences. I've seen the program and the list of talks, and of course, as expected, this has to do with how to do neurosurgery better. But I get to talk a little bit about something on the actual question of how do we better deliver neurosurgical care to all who need it, which is the essence of global neurosurgery. Specifically, how do we use technology and innovation to accelerate neurosurgery capacity building in lower middle income countries? So that's my topic, and let's get started. First point I want to make is that there's this thing called global surgery movement, and this is, and we should be very happy about this. What's happening is that, and this is the global map with countries that are shaded in with blue. These are countries that are undertaking nationwide initiative to strengthen surgical care, especially at the district and regional levels. And if I would say there are more than 45 countries in the lower middle income category that have initiated it, and more countries are following, starting it almost seems like every month. And why is this happening? In 2015, there was a few things that happened. One has to do with a report from the Lancet Commission on Global Surgery that highlighted the magnitude and the scope of the unmet surgical needs in the developing world. 143 million operations are currently being unmet. At the same time, the World Bank published the third edition of the disease control priorities and dedicating the first volume on essential surgery. At the same time, there was the Sustainable Development Goals, which the member states of the UN agreed as the goals we want to try to achieve by 2030. We're only 7 years away from that now. As a result of these things, there was a resolution passed at the World Health Assembly in Geneva in 2015, calling for all member states to strengthen emergency and essential surgical anesthesia as a component of universal health coverage. This is a big deal. This means that countries now have to put surgical care at the top of their health priorities and start looking at how to scale up surgical services for the entire country. This is not an easy task, as you can imagine. It's a large-scale intervention at the national level and requires a system-level approach. How do you do that? Well, first you draw up a plan, a strategic plan. In order to change anything a large scale, you need a plan. You just can't start building without a architectural diagram, let's say. And these are called national surgical plans. And I work at Harvard Medical School in the program in global surgery and social change. I am a neurosurgeon, but I'm actually very much involved in policy development for ministries of health and scaling up surgical care for their country. you can bet that neurosurgical care is a strong component of that because of my background as a neurosurgeon. And we helped support surgical plans in countries like Tanzania and Zambia. And in fact, our team has created a manual for developing national surgical plans. And it's published in conjunction with the UN Institute of Training and Research, UNITAR. It's available online. And because of my position, I'm approached by governments to help support nationwide surgical system strengthening. And the picture on the upper right is actually a picture of a neurosurgeon, Dr. Alfredo Borrero from Ecuador. And he just happens to be the vice president of Ecuador. And so we met actually on the sidelines of World Health Summit in Berlin a couple of years ago, and decided that we will work together, Harvard Program in Global Surgery and the Ecuadorian Health Ministry, to strengthen surgical care in their country. Above and beyond that, the world's really the largest overseas development assistance agency, USAID, has been mandated by US Congress to start supporting efforts to strengthen surgical health capacity. And this includes a treatment of untreated traumatic injuries and in the lower middle income countries. So now the USAID has to fall in line with this. But the best part is that the current director, the assistant administrator for global health at USAID, is a surgeon, to Dr. Artur Gawande. So we have people in places, governments recognizing the need to strengthen surgical systems. And what I would say is the stars are lining up, right? There has never been a better time for surgeons, including neurosurgeons, to start looking at how do we improve surgical systems in our country so that everyone who needs neurosurgical care will be able to access it in a timely manner that's affordable and it's safe. And this is where I work on full time now. So let's look at neurosurgery as a specialty. Our team was able to conduct significant research in 2016, and we published this, the baselining of the unmet neurosurgical needs in the developing world. And we estimate that up to 5 million neurosurgical operations that are needed currently are not being met. And in order to meet these operations, we would need to scale up and train additional 23,000 neurosurgeons, and they will need to be deployed in those countries that are in red and yellow. Those are the countries with the critical shortage of neurosurgeons at the moment. It should not be surprising. A lot of the deficit exists in sub-Saharan Africa and South and Southeast Asia. Now, global neurosurgery is now a thing. And I just have to be respectful that there were many activities that I would consider and that are in line with global neurosurgery, but we never really approached it as a discipline, as an academic pursuit and a system level approach. And so we followed the global surgery movement and we called it global neurosurgery, started publishing papers, and it has caught on. So if you look at the PubMed and search for global neurosurgery as a search term, the number of publications are exploding. I think that this is up to 2018. In 2021, we're at 1,000 manuscripts with global neurosurgery as a tagline. Now, what's even more exciting is that major neurosurgery journals are creating sections and creating dedicated issues on global neurosurgery. The most recent example is the Brain and Spine Journal of EANS. There will be a dedicated humanitarian and global neurosurgery issue. And the best part of that is that they're waiving all article processing fees for that particular issue. And I wish other journals will follow suit. More exciting than that is the launch of the Journal of Global Neurosurgery, which I'm privileged to be the editor-in-chief at the moment. It is open access. There will never be article processing fees. There's no paywall to read the research. And will give preference to research conducted and written by LMIC authors. Now, the WFNS, the World Federation of Neurosurgical Society, has seen the need to start working on global neurosurgery issues at the highest level. And Franco Servadai, was the president when he started this global neurosurgery committee, which I was honored to co-chair with Abdessamad El-Wahabi, who I believe is one of the faculty of this course as well. And Abdessamad and I came together with created a global neurosurgery committee and drafted a global neurosurgery action plan with 5 major objectives. And first is amplifying access. Second is aligning global neurosurgery activity within the global surgery movement, advancing relevant research like the Journal of Global Neurosurgery, assimilating neurosurgical capacity building with global surgery. The alignment of global neurosurgery activity has to do with coordination of all the partners and groups that are working on global neurosurgery, so that make sure they're working towards a same unifying goal. And then last is advocating for universal health coverage to at least include neurosurgical services and care within the package. And I'm happy to report that the action plan has been, for the most part, completed. And now we're moving into phase 2 with actual implementation with some of these projects in Afghanistan and Sierra Leone and so forth. So what I'm seeing now is that, the neurosurgeons have been working in lower middle income countries as volunteer surgeons. Medical schools, neurosurgery departments have twinned with other departments in these countries. And they've done an excellent job of providing training and through a mission model and more of a charity mindset. And that's great. We should be doing that, and we should continue to do that. But what's happened since the last 7 or 8 years is that there's been a shift due to the global surgery movement to approach neurosurgical capacity building in a health systems building blocks approach. And one of solidarity, one where we support nationwide countries' priorities and their desire to build neurosurgical care, surgical care, and we support them. It's a partnership rather than a charity model. And this is, I think this is a good development. This is, I think this bodes well. This will lead to sustainable surgical systems and increased capacity, and do it in a very coordinated manner. And I will tell you, there are currently workshops that are being held for health ministries to help develop these national surgical plans. And I'm part of the group that's giving these courses, along with Dr. Walter Johnson, who was the first person hired by WHO to implement that Resolution 6815 from 2015. He's no longer there now, but he's made a significant contribution to the global neurosurgery movement. So one thing we need to do is we need data. We have to know where we are so that we can get to where we want to go. So we are actively counting now the number of neurosurgeons around the world and where they're at. This information is on the WFNS website. Our group, the Program in Global Surgery and Social Change, the Global Neurosurgery team, will be conducting yet another survey so that we can track and see if we're on track to meeting some of these deficits by, let's say, 2030, which is the end of the SDG era. I will tell you a little, spoiler alert, we're not in any way going to reach those targets. We're not going to have 23,000 neurosurgeons trained by then. And I think this is why innovation and technology can help accelerate the process. And one of the other things that we have to provide when we're working with health systems is that we need evidence to guide policymakers, health ministries, things like how many facilities should a country have to build out in order to meet the neurosurgical needs in the country. How many neurosurgeons should they expect to have and have trained? These are questions that we get asked every day. And so we went ahead and I worked with Tariq Khan from Peshawar, and we came up with this comprehensive set of policy recommendations. These are not clinical guidelines. These are recommendations for health ministries, how to scale up surgical systems to meet the neurosurgical, well, in this case, head and spine injury needs in these countries. And we just published another one on spina bifida, and we expect to do further reports and recommendations on other conditions as well. I think the next one we'll be doing is on brain tumors, CNS tumors, and what will be the policy recommendations for ministries to meet those, manage those conditions in lower middle income countries. Now, let's switch gears and look at the current state of training of neurosurgeons around the world. I trained in the US. It took me 6 years, and I think right now the minimum training period is 7 years. 2 years of research, and you know, it's a long time and super competitive, and there aren't that many spaces, slots in the US. And that same theme is going on in other parts of the world too. There's not enough programs, they're expensive. Sometimes trainees have to pay. They have to pay to be residents in neurosurgery because it's considered because governments consider it part of schooling and education. So I think it's time, when we have this massive unmet need of 23,000 neurosurgeons, to reimagine neurosurgery training. This is a picture of a anatomical lab using cadavers. You can see the cost that will be needed to set up these kinds of facilities. Multiple microscope stations, multiple sets of instruments, multiple cadaver, continuous source of cadavers. These are not easy things to set up, especially in the countries where they have the greatest deficits. These are the lower middle income countries. So how do we reimagine neurosurgery training? So let's go through that. I think there are some innovative approaches that are happening over the last few years, which is really exciting. And I'm very bullish on using technology. The aviation industry has done this for years, and they've accepted simulation time spent in a cockpit, in a simulation cockpit, as equal time in terms of logging a flight time for pilots. We have not used a similar type of approach in neurosurgical training, but I think it's time now. There are multiple reasons for that, but now we have technology with greater bandwidth, internet, better computing power. So technology really has, and especially digital technology, has really revolutionized simulation training, especially in medicine, but more specifically in surgical training. I borrowed this picture from the Upsurgeon website. Sorry, Federico, but I love what they've done in terms of using technology to bring someone from to a place where they are now maybe competent to do certain procedures. And it starts with virtual reality, mental training. And think of this as basically a video game, and the younger generations know how to do this. They use, monitors or just glasses, and they use these controllers. And you can simulate the steps that are required to do an operation with it just in a virtual world, right? There's no cadaver or no models involved. Then you go into a hybrid situation using a model, but using onlay imaging to start practicing on a hybrid model. And then you go into manual training, which is using high fidelity models to actually conduct these operations. Before that, and after that, you go into actual patient care, right? And doing real surgeries. I am so impressed with Upsurgeon's high fidelity models. This is a picture of the craniosynostosis model, a pediatric case. And I think they even simulate bleeding as part of their these lifelike models. And I think eventually, and maybe it won't replace it completely, but the cadaver labs, for multiple reasons, are really very difficult to maintain. I think the lifelike high fidelity models could be really the alternative that takes its place. So let's talk about the numbers again. 23,000 additional neurosurgeons are needed. Now this is let's just assume, and I've did some scenarios, we're able to train up to 500 neurosurgeons a year now. Well, actually, the number is much lower, but let's just say, for the sake of the argument, if we're able to train 500 neurosurgeons a year, it will take 46 years to meet the 23,000 neurosurgeon target, which means year 2069 is when we're going to hit that. Way too long. Even if we double that to 1,000 trainees, neurosurgeons trained a year, which is very ambitious, it will still take 23 years, and it will hit that target in year 2046. Let's work backwards. Remember, SDGs end in 2030. So let's just give us a little bit of extra room. Let's give us a 10-year. Let's say our target is we want to hit by 2023, meet the unmet neurosurgical workforce demands of 23,000 neurosurgeons. By that time, we would need to train 2,300 neurosurgeons a year. That's the target I think we should go for. And in order to do that, current paradigm of training is not adequate. It needs to be revolutionized. And multiple strategies are needed. And first, number one is we need to increase the number of trainees. We need to bring more people in. This is an input problem. Number two, there's not enough neurosurgical training programs. So we need to help set up additional training programs, especially in those countries with neurosurgical deficits. This should be a high priority. And we need to reduce the time to train. And I think this is where the technology innovation comes in handy, because you can really compress the time to train some of these. You don't have to wait till you do 20 operations for a moya disease. You can do it right there, in a simulation training. And then it should be done with some caveats, which is one, their competence should be maintained. We should never sacrifice quality and safety to get there quickly, right? We'll get there quickly, but at the same time, maintain safety. And remember, just because we train more neurosurgeons doesn't mean the delivery of neurosurgical care is guaranteed. We need to still work with health ministries to take a health systems approach. We need nurses, anesthesia, infrastructure, financing. All those things have to be dealt with and built out concurrently. So that's the end of my talk. It's 20 minutes. I just want to give a little plug for the first ever WFNS Global Neurosurgery Symposium. They'll be held in March 10th to 12th in Peshawar, Pakistan. I'm excited. Tariq Khan is an amazing host, and I hope to see some of you there. And another plug for the Cape Town meeting in December of next year, and then 2 years after that in Madrid, the World Congress of Neurosurgery. It's been a pleasure talking with you, and I wish you well in this course, and look forward to seeing some of you in the future in person. Thank you very much.
There is no sound.
I said thank you, Dr. Kipark, for your talk. And if you have any question for Dr. Kipark, please write all questions to me. I will send the questions to Dr. Kipark for answers. Unfortunately, he's not with us, but today we have a pioneer in vascular neurosurgery, Professor Fadi Sharbel, who just joined us. Welcome, Professor. So we will have Professor Fadi Sharbel for two amazing talks today. So the next talk is as mentioned on the program, is talk of Professor Wahabi. He apologized, he can't be with us because of little bit sickness, so he preferred to not be with us, but he sent his previously registered talk. And just give me 1 second, I will share the talk with you. Sometimes technology just stops, like what we have in a DOR when the microscope shuts off, or when the navigation doesn't work during surgery. So it's Professor Abedi, she's with us. She just joined us. Maybe Professor, you want to say hi to all participants?
Hi everybody. I am so sorry today for really miss this amazing course. You know that we participate together, all the team, but for organize it with our university and the foundation, but the really who is in charge of this course is Dr. Fahd Al-Qawi. This is why I give him all the all the liberty to manage all the course for these 2 days. I apologize to be. I will try if I am better to tomorrow to at least past some hours. If not, I will join you by calling. So I just see the talk of our friend Key Park. Thank you to invited him, because we know one of the aims and the roles of the WFNS is to help the LMIC, and we know that Key Park was one of the plaidoyer of this cause, and we had with him organized the first meeting or course in Rabat in 2017. Was the first one, and I think he's talking about the next, but a big meeting of global neurosurgery with Tariq Khan, who was with us in 2017. This is a topic very, very important for us and for WFNS, because it represents at least 50% of the work of the WFNS. And I hope that we can start this program and continue those who was starting many years ago as soon as possible. So thank you for the lectures, the faculty. Thank you for the attendance. I saw that we are 40 till now, and I hope that you will enjoy and learn at least some tip and tricks about during this course, and also these different approaches and these different materials in simulation, which help really very helping today in the formation of the resident. It's after the COVID time. I think it's the second one, and I hope that it will be a series of many others in the future. Thank you, Fahd, and all the team for this wonderful course, and good luck.
Thank you, Professor Abedi, for your nice talk, and we'll do our best to follow your steps. Well, the next speaker is Professor Wahabi. He is, you know him very well. He is the head of the Department of Neurosurgery in Achar des spécialités.
S'il y a un groupe pharmaceutique. C'est quoi son histoire? Billy était la plus brillante.
And so his talk is about terminal approach. Let's go for the talk.
Good evening, everybody. I would like first to thank Professor Najia Abadi for the organizing with Dr. Fahd Al-Qawi this skill-based and vascular surgery workshop. It's for me a pleasure to participate in this workshop. I was asked to speak about the terminal craniotomy. This is a very important approach used in neurosurgery, and I will give my presentation. This is for residents, step by step, how to treat by this approach many lesions such vascular tumors and epilepsy cases. So the first thing is that the terminal craniotomy is the most commonly used intratrans-cranial approach in neurosurgery. It was originally described and popularized by Yazarjil in the 1970s. But since then, there have been a development of this technique. And we can say that the development of neurosurgery as a subspecialty is mainly related to the development of frontotemporal approaches. The frontotemporal, what we call also tenure approach, has evolved with the contribution of many neurosurgeons over the past centuries. But this is one approach that has stood the test of time and has been the most commonly used transcranial approach in neurosurgery, as I said. The hallmarks of the tenure approaches are first, drilling the sphenoid wing as far down as superior orbital fissure, removal of anterior clinoid if necessary, thinning the orbital roof, and opening the sylvial fissure and basal system. All this maneuver and tend to attempt to reduce the brain compression during surgery. When using this approach, we can just with simple modification of degree of head rotation, position, and size of craniotomy flap. Sometime in addition with subtemporal craniotomy, we can have a displaying of a wide scope of intracranial anatomy. This is a simple exposure, but give access to a large and many area in intracranial fossa. There is only one limitation for the beginner, the mental conception and orientation in oblique anatomy, because it is not sagittal nor coronal position, but right oblique. At the beginning, we might have some difficulty in this, but the frequent use of this approach in neurosurgery can overcome quickly this initial difficulty with short learning curve. This is some basic surgical anatomy. You know that the pterian anatomical region is formed around the approximation of 4 cranial bones, sphenoid bones with greater wings, parietal bone, frontal bone, temporal bone. And the pterion with its confluence of 5 cranial sutures, the sphenocaparietal suture, the sphenofrontal suture, the sphenosquamosal suture, and the coronal suture, of course, and the last one is the squamosal suture. This basic anatomy is very important to know when we are doing a flap, and you can see here in the slides the part of the craniotomy with evolved frontal, parietal, and temporal bone, and how we are going to do this craniotomy. Very important are the subcutaneous tissue and also for the area which contain vascular and nervous various structures which are exposed in pterygium approaches, and they can see here that we will expose, of course, the temporal muscle, the superficial temporal artery, the frontal branch of the facial nerve, and we have to take care of all the structure to reduce the complications at, for example, muscle atrophia or frontal nerve paresis or some cosmetic problems. This is the frontotemporal branch of facial nerve. For the resident, they should know that this very small branches come very close to the operative approach, and they have to know what is the position, and you can see it's very close to the zygomatic arch, and during surgery we have to use a subfascial or interfascial dissection to protect this facial nerve and to avoid some paresis of this nerve. This you can see here, there's some slides from the neurosurgical atlas that show exactly the situation of this frontal branch of the facial nerve to have to take in consideration and to remember this position during surgery, as I said, to prevent some complication. What is now the craniotomy technique we are using? And the first step is the patient positioning. This is a very important step. The patient is placed supine with the operative shoulder elevated on a 6-inch roll and placed at the edge of the surgical table. The head should be secured with the 3-pin skull mayfield in a way, very important, to get a flat and unobstructive operative field. The head should be maintained above the level of the right atrium to facilitate venous return and not have venous congestion. So to get a flat and an obstructive operative field, we have to put the contralateral pin of the operative field. This is what I prefer to do. I know that some others do the contrary. The contralateral pin of the operative field placed on the contralateral frontal region. And you can see here on this slides, while the two ipsilateral pins should be on the ipsilateral occipital region posterior to temporal muscle insertion. And with this position, you have a very nice, flat and unobstructed operative field. A right-sided approach is preferable in most midline lesions, of course, for a right-handed neurosurgeon. And for this kind of lesion like ACOM, pituitary, basilar purification, and it is mandatory to get a right-sided approach, of course, in right-sided lesion if the tumor extends in the right side. There is, when making the patient positioning, there is a sequence of 5 movements: traction, lifting, rotation, lateral flexion of the neck, and extension. We go through this step by step. For the traction, the head is moved along with the head holder toward the surgeon. We'll show you in a video. Then the lifting is mean that the region to be operated should be positioned at a level above the right atrium. The rotation around the long axis of the body, this step is very, very important. It depends on the condition being operated. For example, if we are dealing with more anterior lesion, we have to go with a greater rotation. But if we are dealing with posterior lesion, we can just have lesser rotation is needed for this. And in this slide, you can see this is just the angle to treat and for the position. The more posterior lesion, less than 15 to 20 degrees. More anterior lesion, the rotation should be around the 60 degrees. The lateral flexion of the neck is a maneuver to bring the thin toward the contralateral clavicle, but you have to be very cautious about that because severe flexion might compromise jugular venous return. And this maneuver will increase the angle formed by the head and neck. In fact, to prevent encroachment of the surgeon's arm and microscope into ipsilateral shoulder. The last step is to make extension, as this maneuver will allow the frontal lobe to fall away from the orbital roof and reduce the degree of brain retraction. This is very important also maneuver. And you can see here in this video, this different, so we tracked, this is first, but, and then we make a lifting, so elevation of the head, and then the rotation, and then there is an extension, that means posterior extension, and then the lateral inclination or the lateral flexion of the neck. These are the 5 maneuver used during the position. At the end of the position, we should have the maxillary eminence should be elevated well above the superior orbital ridge. Should be the most elevated point in the operative field, and you can see here in these slides. The final position of the head and body. Note that the body is elevated 30 to 35 degrees to further contribute to the reduce the venous pressure in the neck and to avoid the congestion of the venous system. Now the step followed is the skin incision. The goals of is adequate exposure and maintenance of viability of skin flap with minimal trauma to the soft tissue underlying the skin flap, acceptable cosmetic results. The technique you can see on the slides, this is a curving, very gentle curve frontotemporal incision, starting from superior margin of zygomatic arch, you can see, 1 centimeter anterior to the tragus, aiming toward the midline posterior to the hairline. In this kind, of course, the patient was bald, and we put the incision around the coronal suture. And we can see also in this slide, so there's different, this is the mini craniotomy for mini peritoneal craniotomy, and this is the classical peritoneal craniotomy. After making a skill incision and we elevate the scalp, it is very important to protect during section, to protect the frontal branch of the facial nerve. And this is for why we have to do interfacial dissection to preserve frontal branch of facial nerve. And then we will make a section and displacement of the temporal muscle, and this is the fat pad you can see here, and you can see, and we are making just for anatomical demonstration. This is the temporal fascia. This is fat pad, and this is the superficial temporal fascia, and we know that the facial branch, frontal facial branch, is located in the superficial fascia, and then we go in subfacial or interfacial dissection to prevent this kind of paralysis. And this is, you can see here on this slide, how we proceed. Then after that, we go for making elevation of the muscle, and then with the section of periorpsios. And as you can see here, after that, you have to be very careful with elevating the muscle, just not to make a trauma of the muscle, the temporal muscle. And we can leave a part here, a part of the muscle, temporal muscle insertion for closure here. And for the craniotomy, the main objective of the peritoneal craniotomy is to provide a basal and wide exposure of the sylvian fissure. Craniotomy should expose the inferior frontal gyrus and part of the middle frontal gyrus, the superior temporal gyrus, and the upper part of the middle temporal gyrus. This approach allows separation of the inferior frontal gyrus and superior temporal gyrus without their compression against the orbital rim. Traditionally, the peritoneal craniotomy is performed starting from 3 points of trepanation, what we call keyhole. The first trepanation must be set between the superior temporal line and the frontozygmatic suture. The second trepanation performed on the most posterior extension of the superior temporal line, you can see here. And the third one is located in the inferior portion of the squamous part. But since we had some problem with this opening here, with some hollowing of the temporal bone, we prefer to go with not the keyhole approach, but by starting with the keyhole, but starting with a posterior trepanation in the posterior part of the muscle insertion. And you can hear, and you see here you can see the flap, the osseous flap, the bony flap, to prevent this keyhole opening. And then we continue when the flap is elevated with the resection of the lesser sphenoid wing to get access to the skull base. and then the draining of the sphenoid wing and the flattening of orbital roof minimize brine retection. And the purpose of drilling, and you can see here that we should drill the lesser wing of the sphenoid bone, and also the orbital roof and what remains from the temporal squama. And this is very important step to achieve bone flattening to facilitate the basal access with minimal brine retraction. And the slide you can see here, this we are already almost on the anterior clinoid process by seen by extradural approach. And then we go to opening of the dura mater and brine exposure. The opening of the dura mater should be made in a way that when the dura is folded back, the external dural surface adapts itself to the bone surface without the formation of some folds that may make obstruction of the microsurgical field. This is very important to have a flat dura at the end of the bony exposure. And then the second important step after craniotomy and opening dura is opening the sylvian fissure and the basal cistern. The spleening is usually begin at the level of the pars triangularis, where the space between the frontal and temporal lobes is wider. The superficial part of the sylvian fissure is opened using a needle or scalpel blade and microscissors, and you can see. The dissection is usually done on the frontal side of the superficial sylvian vein. Here in this video, we are opening now the sylvian fissure very widely, and then we will get in the basal cistern by opening the lamina. Here we are opening the Liliequist membrane, and we are already in the posterior fossa. And sometimes when the superficial part of the frontal and the temporal lobes are extremely adherent, it is advisable to deepen the dissection into the operculo-ansular compartment of the sylvian fissure to identify the branches of the middle cerebral artery, and then we go through a tunnel dig along the deep part of the sylvian fissure, coming back to the surface, and then splitting the superficial part of the sylvian fissure. So the opening of the sylvian fissure is a very important step in this approach. When we have opened the sylvian fissures and the basal cisterns, you can see this is a nice view of what we can have at the end of this exposure. The pterygium craniotomy, of course, will allow us to reach the olfactory cistern, the carotid cistern, the chiasmatic cistern, the sphenoidal compartment of the sylvian fissure, the lamina terminalis cistern, the interpendicular cistern, the ambient cistern, and even the coronal cistern after the removal of anteromedial segment of the uncus. Though this is very, very wide exposure and very nice exposure for the skull base. This is why these are the advantage of this approach. The tunnel approach allows exposure to numerous important anatomical areas: the orbit, the sylvian fissure, the skull base of the anterior and middle cranial fossa, the frontal temporal parietal lobes, insula, basal ganglia, mesial temporal lobes, hippocampus in epilepsy surgery, upper brainstem, the supra and paracellular area, basal cistern, the cavernous sinus, anterior circulation or anterior circulation aneurysm, intracranial internal carotid artery, anterior and middle cerebral arteries, anterior communicating artery, posterior communicating artery, distal vertebro-basilar system of posterior circulation, mainly top of basilar artery, proximal posterior cerebral artery, superior cerebral artery. So you can see here that there is a lot of possibilities to reach through this approach. So the indication comes from this advantage. So the pterygium craniotomy, since it gives a wide multidirectional access to the anterior and middle cranial fossa, as well as many structures of the interpendicular fossa, the indication permitted by anatomical accessibility are numerous and include high number of aneurysm cases, tumor resection, either intraaxial and extraaxial, epilepsy surgery. So these are the indication of this approach. Of course, there are so few complications. Every single approach can have complication. The complication of terminal craniectomy are not very common. Specific terminal craniectomy, headaches, pain, on mastication, paralysis if the frontalis orbicular oculi is injured, visible scarring and other cosmetic defect, temporal hollowing because of the atrophy of the superior temporal fat, inadvertent breach of orbital or frontal sinus. But most of these complications can be avoided with perfect knowledge of anatomy and perfect surgical technique. And there are some view from the internet giving this kind of complication. So we will go now through some illustrative cases of aneurysm first, and then some cases of tumors. And I pay tribute to the father of micro neurosurgery of aneurysm, Professor Yazarjil, for his contribution in this field and for developing the terminal craniotomy for the skull-based lesion. So what are the cases that you can be clipped through a terminal approach? All anterior circulation aneurysm, ACOM, MCA, carotid ophthalmic, PCAM, carotid bifurcation, but even the posterior circulation, such as distal vertebrobasilar, top of basilar artery, proximal posterior cerebellar artery aneurysm can be reached through this approach. Which kind of which side of craniotomy are we going to choose when we are dealing with aneurysm clipping and when we are doing this approach? So the terminal approach side should be aneurysm side in MCA, carotid ophthalmic, PCAM, anterior choroid artery. But in can be used as right craniotomy in ACOM, exception if there is a dominant left A1 or additional left-sided aneurysm. That means that in this situation, we have to go from the left to have a better control of the aneurysm, or if there is another aneurysm in the left side, can be clipped in the same procedure. The head position is very important and should be adapted to aneurysm location. In general, as the aneurysm is located anteriorly, we need more rotation. As the aneurysm is located more posteriorly, we need lesser rotation. Then, for example, for ACOM, we can have 50 to 60 degree rotation of the head. MCA around 40 to 45, the carotid bifurcation, carotid and wall and posterior communicating around 30. For the aneurysm of basilar, for example, trunk, interpeduncular system around 50 to 25. But you have to know that this is not something that is completely fixed. The neurosurgeons should have the capability to move around the operative field and also to modify the microscope angulation if sometimes to have a better exposure during a clipping of aneurysm. And this is some illustrative case. This is a posterior communicating artery had been treated by clipping through a terminal approach. This is a partially thrombosed posterior communicating artery aneurysm, and this is the arteriography, and we will see the approach. And in this situation, you can see nice approach with the optic nerve, the carotid. We can see already we see the aneurysm. The neck was very not very large, and in this situation, we also open the sac to decompress the third nerve, because there are the third nerve palsy in this situation. So the approach gives a very nice view and without any further bone removal. But in situation like in paracrine with aneurysm, we need to work on skull base by removing the anterior clinoid. We do this in all our cases by intradural resection, and this is a case, the carotid-ophthalmic large aneurysm with mass effect on optic nerve. We operated through a pteryginal approach with you can see here, to clip the aneurysm and to decompress the optic nerve. And now this is the approach, and we are doing the anterior clinoidectomy to get access to the neck. And this is the falciform ligament on the optic nerve. We go also with unroofing the optic canal and drilling the clinoid, anterior clinoid process, as I said, to get access on the neck of the aneurysm. And now so far we are opening the canal and the section of the dura ring, and then we'll see and we can individualize the neck on the aneurysm. You can see here, this is on ophthalmic artery, and now we can have an idea about the neck of the aneurysm. We'll make an exclusion of the neck of the aneurysm. Okay, we can have access through this anterior clinoidectomy, and then the second step is to open the sac and to decompress the sac. Okay, we open now the sac, and then we cut it completely, and okay. That's it. Okay. Sometimes we have to discuss about this approach for some basilar trunk aneurysm, and this is a young guy who presented with subarachnoid hemorrhage with the basilar trunk aneurysm, and we review the radiology study, and you can see here that the aneurysm is well above the posterior clinoidal process. So we decide to go with the pteryginal approach. The position of the head was around 15 degrees of rotation, and then we can get access to this aneurysm by this, after opening, of course, and splitting the Sylvian fissure. We get access to the aneurysm. And we can make an exclusion of the aneurysm. This is the Lilliquist membrane. We are already in this basilar trunk, and the aneurysm is here. And after some maneuver to have adequate angle of attack of the aneurysm, and then we found the best way to do this, and then the aneurysm was occluded. Some tumor cases, and this is meningioma resection by this as the approach. This is just a very short video. This is the anterior clinoid meningioma after opening the after making pteryginal craniotomy and opening the Sylvian fissure. We have got access on the tumor, and you can see here we make a very good removal of the tumor, and you can see the polygon of Willis, very nice carotid, anterior cerebral artery, carotid bifurcation, optic nerve, and total removal of the tumor. This approach really is very nice and get very good exposure to many of skull base lesion. This is a case of craniopharyngioma presented with hypertension and visual field deficit. We go with this is the approach. You can see the optic nerve. We are in between the anter-optic approach here, and we can dissect the capsula from the surrounding structure very nicely. This is just to show you that this approach can give you a good exposure for this craniopharyngioma. Since it was, there is an extension posterior interpeduncular fossa, we use rotation around 15 degrees of the head, so to get access this posterior part of the capsula, and then you can see that the tumor will be removed totally with in this situation with the preservation of with the pituitary stalk at the end. Okay, tumor has been removed totally, and this is the pituitary stalk can be preserved. So this is, I mean, just to show you that we can see with this plenary approach around all the structures during surgery. Some cases that also the craniotomy, frontotemporal craniotomy can be used, but in this situation, we have to use a large frontotemporal craniotomy, mainly in case of WEAC surgery, because we need brain mapping during surgery, and this is a case we use the frontotemporal regional anesthesia during a WEAC surgery. And this is a case has been treated using this large frontotemporal craniotomy and with total removal in this situation. And you can see this is the craniotomy can be completed by subtemporal craniotomy to get access to all the temporal lobe. So these are some just illustrative cases of the utilization of this technique. In conclusion, we can say that frontotemporal craniotomy, known as pteryginal craniotomy, provides an optimal microscopic exposure and wide open working space for manipulation of intracranial structures. Since its introduction, it has been widely used in the field of neurosurgery for treatment of lesions in the anterior and posterior circulation. The pteryginal craniotomy provides wide, multidirectional access to the anterior and middle cranial fossa, as well as many structures of the interpeduncular fossa. Complications of the approach are very rare and can be avoided by perfect surgical procedure and perfect the way to do perfectly, because they are going to use it most of the time all their lives. Thank you very much for follow this presentation.
Thank you, Professor. Thank you, Professor Wahabi, for this brilliant talk. And if you have any question, please, I will receive them by email and send all the questions to Professor Wahabi. Our next speaker is Professor Fadi Charbel, well-known neurosurgeon. I don't need to introduce him to all the community. He is inventor and brilliant neurosurgeon, head of the Department of Neurosurgery at the University of Illinois at Chicago, USA. And welcome, Professor. And please share your slides and your knowledge with all participants, especially your experience. Thank you so much.
Thank you very much, my dear friend, Dr. Derkawi, and congratulations for holding this course again. It's a real pleasure to be with you. I have some fellows and medical students here, many people listening to this excellent lectures that we heard this morning, very educational. Thank you to Professor Al-Wahabi for his fantastic didactic lecture. It made my talk a lot easier, so I don't have to go over that again. So it's great to see you, good friend. Ed, if you don't mind, could you let me in? I'm trying to log in from my laptop also, so that I can run my
yes,
my
please.
talk through the laptop.
Yeah.
There we go. Great. So I'm going to mute this.
We don't hear you yet, Professor.
How about now? Can you hear me?
Yeah, yeah.
Okay, great. You hear me all right? Sorry to ask again.
Yeah. I think it's okay. It's okay.
All right. So principles effect of aneurysm surgery in about 20 to 30 minutes. These are my disclosures. I have a financial interest in the flow probe, and I am disclosing that. Okay, why do we operate on aneurysm? It's important to think about that in the beginning of what we do. The principle of operating on aneurysm, whether surgery or endovascular or anything, is we want to exclude the aneurysm from the circulation. Okay, so we can do it by putting a clip directly or coils, or we can do it indirectly by using flow diverters, proximal occlusion. And we want to do that while at the same time we're preserving flow in the distal branches. So that's really the principle of what we do. What are the steps? For me, there are 12 steps. 12 steps is a kind of a popular thing in the various situations. So the 12 steps are here. Let's start with the incision and the craniotomy, and I will tell you that that is a personal choice. So what you have heard in the previous talk is the absolute workhorse that you must know, and it was very well illustrated. So the pterional craniotomy, which you see here, the black line is the pterional craniotomy, and that is very well established, and that's your workhorse. Over time, you can see different variations, and maybe I'll talk a little bit about a couple of them. The mini pterional is the same thing as a pterional, meaning a craniotomy that is centered on the pterion, but it's small. So you make a smaller incision. You still have to cut the muscle, and you still have to drill the pterion, but it's just smaller. And you can do that if you're comfortable. Juha Hernesniemi, a very famous surgeon from Finland, popularized another approach that's called the lateral supraorbital craniotomy, which looks like this. So there's less cutting of the pterion. The main difference is the incision does not reach the zygoma. And the muscle is cut, but not a lot. The pterion is still drilled, and that's the LSO, of Vyuha Hernesniemi. My preferred approach for anterior circulation aneurysms is a modified LSO, modified lateral supraorbital craniotomy. So if you see the supraorbital craniotomy like this, mine is a little bit less, meaning that it looks like this. So it stops just about at the level of the superior temporal line, which is here. That's the superior temporal line. And the craniotomy is what you see in red. And that's what it looks like. So the muscle is elevated, disinserted from the superior temporal line rather than cut. Now, the difficulty with this is if you're not familiar with it, when you open the dura, you're just going to see frontal lobe and you will be disoriented. So I do not recommend it in the beginning, but ultimately with CSF drainage, etc., you can do everything, all anterior circulation aneurysms and tumors, etc., can be done with this approach. And that's the size of the craniotomy, and that's what it looks like. You see an ACOM aneurysm that was clipped through that type of craniotomy. And here's a MCA aneurysm that is being approached. You see we're measuring flow here into the aneurysm, clipping the aneurysm after temporary clipping. You see it's a small aneurysm, so it's important to have a temporary clip placed on the M1. And then one nice trick is you can pull the aneurysm into the clip, which is helpful, especially in small aneurysms, so you can really get it properly. And then the clip is removed. And all of that is done through a relatively a small approach. Here we're checking the flow after clipping to make sure that we didn't compromise it. You can see it's a focused approach. Okay, we can do a lot of things through that. I won't show you this video. This is a video of clipping 4 aneurysms, 2 on the MCA, 1 which was a recurrent anterior communicating artery aneurysm that was coiled, and a contralateral MCA aneurysm. All of that was done through this craniotomy. You see how big it is. Okay, so it's possible to do that, but you have to be comfortable with it. So it's important to be minimal. Here's a pericallosal aneurysm. You see it's a frontal craniotomy, parasagittal, but there is a vein here. So the dural opening was very small. And even with a very, very small opening, if you take your time hearing what's splitting the interhemispheric fissure, we're seeing the aneurysm, we're measuring the flow, clipping the aneurysm right here, placing the clip and securing everything, checking the flow again. And you can see that it's a very, very small approach here. It's about a 7 millimeter to 1 centimeter approach, dural open. Okay, so you can, if you apply yourself, do smaller craniotomy, but do not start with that. Listen to what Professor El-Wahabi showed you. Okay, now vessel flow compromise is the second thing we're going to talk about. This is the big problem for aneurysm surgery. You have to clip the aneurysm perfectly, but remember the second directive is you have to reserve flow in the outgoing vessel. If you do not preserve flow, it can be a big problem in the following situations, especially if you compromise big vessels like a carotid or bilateral ACOM. But it can also happen indirectly. See, we always think of direct compromise. You put the clip on the vessel, you see it, you remove the clip. But it can happen indirectly. It could be atherosclerosis, it could be a kink of a clip, and so forth. That's why flow measurement is important, you see. So how do we do that? You measure flow, so that's step 7 and step 10. Remember we said scalp incision, craniotomy. After you do your craniotomy, the first thing you want to think about is proximal control. Proximal control, proximal control, proximal control. You have to constantly hear in your head, I want to get proximal control. Once you get proximal control, the second thing, you want to identify the neck and think of a clip you're going to use. You want to have that clip ready. You want to have your scrub nurse, whoever it is, have the clip ready, at least for a tentative pilot clip. And you want to have a temporary clip ready as well. So a lot of times the nurses, they don't know what they're doing. They're not very helpful. So you may have to tell them to load the clip and have it ready for you. So you have to have 2 clips ready, a temporary clip and a permanent clip, pilot clip ready on the field, okay? So after you do that, if you can, you get distal control. And before you clip, you check the vessel at risk. And then you want to check them afterwards. So that's step 7 and step 10. We're going to talk about those 2 things. There's many ways you can assess patency. You can look at it. You can do an angiogram. You can do ICG. You can use a Doppler. Flow measurement is, of course, very important because flow gives you flow. And otherwise, the angiographic patency only tells you that the vessel is open, it's not flow, the diameter is not flow, the velocity, of course, is not flow. The problem with velocity is if you don't know the diameter, the velocity can increase with the stenosis. So you think things are got better, but they're not, okay? But I understand a lot of places you don't have flow measurements. So you do what you can, but keep in mind that if you're not measuring flow, there are limitations. So be aware that a velocity is not necessarily flow. Be aware of all those things. Okay. Here's an example. That's somebody that had a PCOM aneurysm coiled before. So we check the flow at baseline and the PCOM because that's an important PCOM and the P2. The baseline flow is 14. So now what I'm going to do is clip the aneurysm, see proximal control of the carotid. That clip is on the carotid, that clip is on the PCOM, and this is the aneurysm right here. So the clip is going on the aneurysm. I'll put the clip as best as I can, but that's an important PCOM because it contributes to the PCA. So we'll remove the clip. Now we're going to see, we're going to remove all the temporary clips. There you go. So that's a right-sided approach, of course. And then what we're going to do is we're going to check the flow again in this PCOM. So check the flow in the MCA first of all. The MCA flow is stable. That looks good. Check the flow in the PCOM. See the PCOM here. PCOM goes medially, right? You approach it medial to the carotid, not lateral. And you see the flow went down. So what's the problem? I readjust the clip. I check the flow again. The flow is still low. I adjust the clip. I remove the clip while measuring flow because maybe it's spasm, maybe it's not the clip. And the flow normalizes. That's how you know that it's the clip, you see? So, okay, so it was the clip. So I have to do a better job. So I spend better time, I dissect better, and I really apply the clip as best as I can. I'm looking at this PCOM from one side and the other. I clip it. I think now it's good. We'll see. Remove the temporary clip. And now the P2 flow is stable. And let's see the PCOM and the PCOM flow is back to baseline. You see? So you can do all those things with a very limited approach, but in this particular case, it was essential to do all those moves because it was an important PCOM itself. The artery itself was important. Okay. Another scenario where flow is really important is this one. You see this pattern when you see a lot of blood in the basilar cisterns and an aneurysm that looks like this. Don't make the mistake that it's a simple aneurysm and an ophthalmic or something like that. This is usually a pseudo aneurysm. You see that? It comes from the carotid itself. It doesn't fit a pattern of a carotid, ophthalmic, or a hypophyseal, or a PCOM. The whole carotid artery is diseased. It's a dissection. Okay, so when we published it, we call it pseudoaneurysm. And if you approach this carotid is going to look like this. Okay, it's going to be a total hole in the carotid. It would fall apart on you. So you have to be absolutely ready to do a reconstruction. And sometimes you may have to do a bypass or you have to clip wrap it on all those things. But when you do that, you are compressing the carotid. So it's really important to check the flow. And here, look, by changing the aperture just a little bit or the sling, just a little bit, the flow goes from 30 to 55. So it's like a 50% improvement. Okay, that's all I'm going to say about flow measurement. Step 8 is called mobilization of the dome. This is a very, very, very important step. If you don't mobilize the dome, you have not clipped the aneurysm properly. I'll show you an example of that. Very often what you have is a vessel that's indirectly compromised. It's adherent to the dome, like this one. This is an MCA aneurysm, looks very simple. There's a vessel that comes behind it. It has nothing to do with the aneurysm. It doesn't come from the aneurysm. But look what happens at surgery. The aneurysm is clipped. We're looking at ICG, and the vessel is patent. I'm going to show you again. Here's the ICG. See this vessel? It looks very patent on the ICG after clipping, right here. Right here. See it? Looks great, right? Well, let's measure flow in it. Here's the flow being measured. The flow is 1.6. That's low. How do we know it's a problem with the clip? Well, that's what we do. We open the clip a little bit, and what happens to the flow? It more than doubles. So it's the clip, obviously. Why? The clip is not on the vessel. Well, the reason why, so you remove the clip and you take a look. The reason why, see that vessel? It's adherent to the dome. And when the clip squeezed the aneurysm, it pulled on the vessel. So it's indirect. So you have to always mobilize the dome and look around and be sure. So now the vessel is dissected sharply, 360. And now we can clip the aneurysm properly without a problem. So the aneurysm is clipped. See, the aneurysm is secure. The vessel is secure. And how do we know that it's dead? Because we cut it and we put a hole in it. Okay. The last thing that I will talk about is this. How do we know that an aneurysm is secure? Remember, what is the goal of the surgery? We have to exclude the aneurysm from the circulation. How do we know that? Well, there's only one way to know for sure. You can do all those things. You can look at it. You can do a DSA. You can do an angiogram. You can do an ICG. Look at these ICG. This is the aneurysm ICG post-clip. Does it look secure? Looks dark. How about this one? Looks pretty dark. How about this one? Looks also dark. And how about this one? It's also dark. None of these were secure. None. Okay. So angiographic obliterated aneurysm is not always secure. This is why you have aneurysms sometimes that are coiled, and the endovascular coil is say, oh, looks great. Well, it's not. Coil only fills 30% of the aneurysm. It's relying on thrombosis for securing the aneurysm over time, and that's why sometimes coils recur. So look at this here. Look at this example. The aneurysm is clipped. It looks completely dead. And what I'm going to do is I'm going to cut it. Look what happens when I cut it. You see that? It's still alive. Still alive. So here's something that you can do before you cut the aneurysm. We call it the squeezing maneuver. We published that with my Italian friends. Look at this aneurysm here that I'm operating on. Here's the clipping. Here's the ICG. Looks dead, right? Use this. It's called the squeezing maneuver. Watch. Very simple, very safe. Squeeze the aneurysm. If it refills, you know it's not dead. So before you put a hole in it, squeeze it. Okay, squeezing maneuver. And that is how you know it's dead. Then you adjust the clip and then you cut it and you know it's dead. So here's another example of the squeezing maneuver. This is an aneurysm of the pericallosal. It's a complicated aneurysm that's adherent to a calloso-marginal branch. So you see how adherent it is. So it required the transposition of this vessel that we cut, and then I reimplanted it on the other branch. And once this is done, the aneurysm became pretty simple, and now I clip it. It looks great, nice clipping, easy, no problem. And look at that, it looks dead, right? Well, let's see if it's dead. Squeezing maneuver. It's not dead. You see, it's not dead. So we have to do more, put an additional clip, and now it's dead. Okay, so these are the 12 steps. Think about them. Your technology, if you have it, use it. Your technique comes with time and practice, but your thought process is the beginning. 12 steps, scalp incision, craniotomy. First thing you're going to think about, proximal control. Then where is the neck? You have to have a clip ready for temporary and for pilot. And then once you do that, distal vessels, get distal control. If you have distal control, that means you dissected the aneurysm better. You can mobilize the dome if you can, check the flow in the vessels at risk before and after, whatever you use, do before and after. If you can measure flow, it's ideal. Once you clip the aneurysm, repeat, and then ascertain vessel occlusion. Progressively, the first step, squeezing maneuver. Second, you can put a needle in it. Third, cut the aneurysm open. And that is my talk about the principles of aneurysm surgery.
Thank you so much, Professor Fadi Charbel, for this amazing talk. Can we have some question here? We'll have some question for Professor Fadi Charbel. No one? Let's participant think about that. And what do you prefer, Professor Fadi? You wanna go further with your second talk, or
whatever you like. I'm happy to sit and watch. I'm very happy to join you. I wish I was there in person. So I think we can stay with the schedule to respect the other speaker.
Okay, let's go for that. So we are waiting your questions, and the next speaker will be Professor Marco Cesato. He's traveling in Asia, and because problems with the connection, he preferred to send Professor Marco Cesato is he is a professor of neurosurgery in Milan, Italy.
Hello, I'm very happy to be here and to be invited by Federico Nicolosi to present my experience on intracanal aneurysm. And I think that what he has created, so these models for mental and practical training on intracanal aneurysm are something really important, because for residents to have the occasion to practice on an intracanal aneurysm is not easy. On a cadaver, you don't have any aneurysm, and so trying to understand how the 3D anatomy is not very easy and common. So having the opportunity to manage, to train, to try to see how an aneurysm is located in the 3D world of a Sylvian fissure or the deep surgical field is not a common experience for a resident. So I really believe that these are a very important adjunction to the surgical training. So I will present my surgical tips and my suggestion on how to manage this difficult situation for the intracanal aneurysm. First of all, we will do something on MCA aneurysm, which are the most common, and what now we have more frequently to deal with in the surgical field, because many of the aneurysms are now treated by endovascular. So first of all, the position for MCA aneurysm is, of course, a pterygium approach, and the angle of the head is generally 45 degrees, but this will change if you are treating anterior communicating artery or a PCOM aneurysm. You have to change a little bit the head position. What is important, and probably you don't have the occasion to do that on this model, but I am sure that in the near future, this will be done. One of the main important situations you have to deal with the aneurysm is to deal with the arachnoid. As you know, The willow circle is within the cisternal space, and so you have to know that how the cisterns are and how to reach them, because everything is located in the basal cisternal compartment. So first of all, you have to learn how to open the sylvian fissure and how to reach the basal cistern. You can you can use either microscisor and forceps, and gently you have to alternate these two techniques to open gently the sylvian fissure. It's important to split the sylvian fissure and try to keep the sylvian vein on the temporal lobe, because many of them are in most of the cases, they go to the sphenoid wing on this on the temporal lobe, and so
Sir, we have no sound.
Do you have a problem of sound?
Now we can hear you. But we have no sound on the video.
So you don't have sound in the video?
No.
Okay, sorry.
we have all learned how to operate with a
now it's good. It's perfect.
retractor, because we all know that they can damage, keeping a retractor on the brain surface can damage the brain. So it's much easier and much safer not to use them. And so keeping the sucker and the aspirator on the non-dominant hand, and then use a dissecting instrument on the dominant hand. Generally, a slightly curved dissector is important, and because with this and with an instrument like this or similar, you need to expose the neck of the aneurysm, and in most of the case you can avoid to expose the dome, which is the most fragile part of the aneurysm. What you need is to find the neck and check the neck where you have to apply a clip. So after you have opened the Sylvian fissure, you will find the M1. You need to find the M1 because having the control of M1 is mandatory, because if the aneurysm will rupture, you have to have a control on that. And then try to follow the vessels, the distal branches, to reach the bifurcation where, in most of the case, the aneurysm is. Like in this case, you can see here the M1. This is the frontal branch. This is the aneurysm, and you can, with the instrument and dissector instrument, you can expose the neck and try to understand how it's situated in the bifurcation. And then this is the frontal branch, and then you need to check the temporal branch. So mandatory is to have a proximal control. So in ruptured aneurysm, you generally prefer to go from proximal to distal, while in unruptured aneurysm, you can, if depending on how the direction of the aneurysm is, you can also go from a distal situation, distal direction, but you need to have a control on the M1 that sometimes can be reached also from a distal, from the distal Sylvian fissure. To put a clip generally is mandatory. It's important to pay attention to the perforating branches, and so you need to have a control on them, and so you have to check where they are. For doing that, a temporary clip can be useful because it will soften the aneurysm, and it allows you to move the aneurysm and the bifurcation more safely. This picture shows you that to put a clip is better to put it perpendicular to the aneurysm neck, perpendicular to the bifurcation, rather than tangentially to that, because in this way you will keep better close better the neck. We present you a clinical case. This is a classical MCA aneurysm. As you see, this is directed upward. So when you come from the Sylvian fissure, the dome of the neck will be downward, embedded in the brain. So you will see the neck, and you will not have the control of the dome. As you see here, this is the aneurysm, and the MCA is exposed, and so I will first put a temporary clip, and then after that it's easier to check the neck, to check the passage between the neck and the two main branches of the M2 of the bifurcation. This is the frontal, and then here I will go to check the emergency, the temporal branch, how it emerges from the bifurcation. And here you will see that there will be a room to put a clip. And here on the model, you can try to train yourself to expose the neck, to look where, how to learn how to manage the bifurcation aneurysm, and how to expose and check how the neck is made. To check the clip, to choose the clip, is important to choose it when you have the control of the aneurysm. I think that it's trying to figure out in advance which clip you need is not very important. You, of course, need to have a variety of clip because each one can be useful in a specific situation. So when you have exposed the clip, the neck, then you try to figure out which one is the right one and how to put it and to close the clip. It's very important to release the clip very slowly and very gently and do very smooth movement because you have to remember that the aneurysm is something fragile, and so it's important to move very smoothly. And it's important also to check for the tip of the two branches of the clip and to check if they reach all the final, or if they will take all the neck. Here you can see that after putting the temporary clip and after checking the neck, then you can release the clip, and it's important to notice how gently and how softly you will need to release it. And also here you see that it's important to see that the tip of the two branches of the clip to check if they will completely occlude the neck. Also here you can try to put a clip, try to understand how to release it and how to spare the two vessels and how to completely get the coil, the neck of the aneurysm. Also here you can see with a temporary clip you can manage the aneurysm and try to put all the neck within the clip. And so you can pull a little bit the clip, the aneurysm to be completely reached by the clip. So after clipping, you need to have a way to check if there is any problem. Neurophysiological monitoring is much safer, and so if you have it, they are important. And now the standard for clipping it also is a simple aneurysm is important to have neurophysiological monitoring. Of course, you need a visual inspection, but with the ICG video angiography intraoperative, you can check for the vessels and the main branches, but also for the perforators, which are the most dangerous part of this kind of aneurysm. Microdoppler can be also important. And finally, you need to have an angio-CT or an angiography after surgery. And this is the intraoperative ICG. As you can see here, M1 is open, temporal branch is open, frontal M2 is open, and here the aneurysm is excluded without contrast in it, as you see. And this, in this case, this is a postoperative CT angio. This is the clip, and you can see that there are the two branches here. This is M1, and you will not see anymore the aneurysm. Of course, what is more scaring for every one of us, and especially for a resident, intraoperative rupture of an aneurysm is something that everybody will be afraid because it is something that is very difficult to control. So you have to keep calm, and this video will show you how you can manage it. So this was another case, a very simple aneurysm, an MC, left MCA aneurysm, and in this case the aneurysm is directed to the superficial. This was a very small very small craniotomy, and this, you see, this was the craniotomy. There was no burr hole, just a small craniotomy. This is the size of it, very little, very small, just focus on the sylvian fissure. And this is, as you saw before, opening the sylvian fissure. Little by little, you will expose the aneurysm. First, you will see M1 in this case, and here this is M1, and this is M2, and this is the neck of the aneurysm. This is the temporal branch, and this is the frontal branch. Here you see this is the neck, and this is the temporal branch. This is the frontal branch. This is M1, and this is the aneurysm. Sorry, this was on the left side. And then after checking the neck, as I told you before, here I will put the clip, and you see here is the neck, and this is the release of the clip. And try to release gently the clip, as you see here. And this is a very slight and small release, but as you see here, there is a remnant. The neck is not completely occluded, so I had to remove the clip and put a different one. But in this case, the clip has to be repositioned, but here it's happened something which is not very pleasant. The clip slipped out from the plier and directly ruptured the aneurysm. As you can see here, this from now the video is in real time, and you can see here that you need to have a strong aspirator. Be helped by the second operator and try to suck the aneurysm and try to see something. Of course, it's a very stressful moment. Use a very strong aneurysm and sucking the aneurysm, the surgical field. You can try to put a clip somehow to stop the flow, and you see here that after using a strong sucker, you can finally understand something, see where the dome is, and you can see here that this was the previous clip that was within the sac and ruptured the sac, so trying to find the right clip. Now you will see that I put in a clip somehow just to stop the aneurysm, and of course this frontal branch has been taken on it. After that I have to take out the first clip, take it out, and then once you have understand the anatomy, this is the frontal branch, this is the temporal branch, then I have to reposition it, because this is of course something that does not is not correct, and here finally I reposition the clip and obtaining the control of the aneurysm and of the as you see here, this took out a few minutes, but you have to keep calm and try to understand how to manage the situation. But what I want to stress out is that also in a very small surgical field as this is, you can, if you have the right, if you keep calm and you don't panic, you can find, you can also here manage correctly the situation. And this is the intraoperative ICG, where you can check that either the frontal or either the temporal lobe, temporal branches are open and that the aneurysm has no flow inside, so the aneurysm is secure. And this is the postoperative CT scan. You see the clip, the artifact of the clip, but you don't see any aneurysm sac. The two branches are open, and the patient awoke without any deficit, and she was discharged on day 3 from the surgical procedure. So what happened? The problem was that the applier was not inserted correctly into the clip when I tried to remove it. As you see here, it was not centered on the clip, and this was the reason why I didn't get correctly the clip, and this is why the clip slipped away from the applier. Also, another consideration you can take from this video is it would have been better to use a straight clip rather than a curved one since the beginning. So thank you for your attention and have a good training, and I hope you will enjoy this wonderful model that Nicolosi and the Upsurgeon Society gave you the opportunity to play with. Thank you and bye.
Thank you, Professor Marco Sensato. Any comments from our faculty? Any question from the participants? Professor Fadi Shabel?
Thank you. I think this was a very didactic lecture.
Our next speaker, but let me ask you a few questions before going to bypass. Do you use lumbar drainage?
No, I used to use lumbar drainage many years ago. Can you hear me?
Yeah,
but no more. I don't think it's necessary at all for aneurysm surgery, except only one exception for subtemporal approach. Subtemporal approach, it's imperative to have excellent lumbar drainage. Other than that, now with a good understanding of the subarachnoid drainage, we do not need it.
Great. Another question. You know, when we want to have tools for aneurysm, we go for book like this from the manufacturer, and you have to choose. So what is the best kit of tools for aneurysm surgery, in your opinion? And second question also about clips. How many number of clips do we need to have? Should we have all sizes, all kinds of clips? You know, in low and medium income countries, clips cost money. It's not easy to have all these clips in many centers, and sometimes we don't use many kind of clips. So what is your advice about tools and clips?
Yeah, so I that's a great question. and I see people with the big books and bipolars and 5 different bipolar sizes. I have 5 instruments, 5. A number 8 sucker, a number 6 sucker, a micro bipolar, a regular bipolar, and micro scissors. That's it. Really, it's 3 instruments: a suction, a micro bipolar, and micro scissors. That's it. I dissect with the scissors, and I don't use any blunt dissection. Now, for the clips, though, on the other hand, I have all the clips. So for the clips, if you can afford, have as many clips as possible. But for the instruments, you do not need long, short, this and that. You can take a long bipolar and hold it closer. So get a good size bipolar, and you can move your hand. There's no reason to have 5 different sizes of bipolar. There's no reason for that, in my opinion. I never had them. I know Professor Yasser Gil will tell you, hey, you need to have the entire set. Professor Yasser Gil, of course, is our mentor and our father, and we love him. But 3 instruments, suction. I have 2 size suction, micro bipolar, regular bipolar, micro scissor, 1 size micro scissor. That's it. Not long, short, 1 size.
Thank you so much.
You see my videos, that's all you see. You don't see anything else?
Yeah, exactly.
Yeah.
Exactly. I don't know if there's any comments from the faculty or from the question from the participants. If not, please, Professor Fadi Shaber, will you go to your next talk about bypass? During this workshop, we will have micro is bypass simulation device that will allow participants to practice bypasses on silicon tubes. So please share your.
So it's again my pleasure, Professor Fahd Derkawi, to participate in your amazing workshop. I see so many people. A lot of people are participating on Zoom, and I know there are people in person. We have many of our students and fellows here listening to your lectures. Congratulations on doing it again. And of course, our president-elect of the World Federation, Professor Najia El-Abbadi, your mentor, is our leader, and we are very happy to I'm very happy to participate. Thank you for inviting me. I'm going to share my.
Fahd, maybe.
Yes, Professor.
Hello, Fadi. How are you?
Hello.
I'm very happy to see you and see all your residents around you on your beautiful office. And really apologize for this afternoon to be not able to follow all the lectures, but I follow your 12 steps for aneurysm, of course. And really, we are very happy to have you in this course. We know that you always say yes when we ask you to participate in a seminar, course, or symposium. Thank you for that. Thank you for your young resident to attend. I see them very, in front of you, listening carefully what you are saying, because every word you say is the wisdom. And we know that not only in the neurosurgery, you are one of the pioneers in the vascular surgery, not only vascular, but vascular it's your field. But in your life also, you have to know to I'm telling that to the attendees and to your resident, and I'm sure that they know that before me, that you have a great chance to have this really outstanding professor of neurosurgery and an exceptional person. Thank you so much for to be always to to tell always yes for when we ask you to participate in any events. And good luck. Thank you,
very
ma'am.
much.
Thank you.
Professor Elabadi, you are too kind, and I know you're very busy, but you never fail to say the right word at the right time, and I really appreciate you taking the time. You always make us feel very welcome, and I know that's why you have so many faculty, students here, because they're all very welcome. You're not only a superb role model as a physician, but you're a leader of all of us, and I know everybody appreciates everything you have done. So it's an honor and a privilege to be with you and to be your friend. I will share.
Thank you so much.
So I will share my screen, and now my talk is about bypass. And what I'm going to do about this with this talk is to talk about key concepts. So I will not talk about technique, because you're going to, well, you will see some technique, of course, but you're going to go in the lab and you're going to practice. This is where you learn technique. But it's the concepts that I think very, very important. That's what's going to make you different, and it's going to help you design the proper surgery. This is not a new surgery. Here's Professor Yasser Gil, October 30, 1967, when he did the first surgery. He did it at the same time as Professor Donaghy, because there was a time difference. One was in Europe, one was in the United States. But Professor Yasser Gil is the father of microsurgery and the father of bypass surgery. And I think it's very symbolic that October 30 is actually my birthday. So maybe I was destined to do bypass surgery. These are the concepts that we're going to talk about today. And hopefully this will help you in understanding how to build, it's like construct architecturally the right surgery. Okay, the most important question in life is why, right? Why anything? So why do we do a bypass? And if you really remember this, you will do the right surgery. There's only two reasons we do a bypass. No 3, no 4, no 5. So only two. Either the flow is low to start with, like ischemia, typically moya, and we want to increase it. That's a flow augmentation bypass, and that has a number of rules to follow. Or we have a flow replacement bypass, like for an aneurysm or a tumor, where the bypass is done to correct a deficit that we create ourselves during surgery. And that has another set of rules to follow. If you start by understanding exactly the reason you're doing a bypass, you will construct your operation simply and safely, and you will achieve the goal, and there will be no guessing at the end. So that is the most important thing. If you only remember this, mission accomplished. Okay. In order to build the bypass properly, you need building blocks. You need to understand building blocks, and I'm going to give you those blocks. The first one is something called cut flow. What is the cut flow? Cut flow is if you're using the STA, before you connect it, you cut it and you measure the flow in it. You can measure it with a flow probe. You can measure it by letting go into a little container that's graduated, whatever. But you measure the cut flow. That is very, very important, because that will tell you if this STA can give enough flow or not. And especially this is important to understand this, which is the cut flow index. The index means after you do the bypass and you measure flow in the bypass, you compare it to the STA, cut flow. And now you understand the difference. And once you look at that, you'll have a greater and greater understanding of what happened. Did you achieve your goal or not? And as this lecture progresses, you'll understand what I'm talking about. So the index means if I have a bypass that can give 100 cc's of flow, and I connect it, and the bypass now is 50 or 10, let's say it's 10. It can give 100, the STA, you do the bypass, it's 10. What does that mean? Is it the same thing as if the STA was 10 and the bypass is 10? And you can see that it's not the same thing. right? So you have to start asking yourself the question, why is it different? Okay. When you measure the cut flow index, the cut flow index in the flow augmentation bypass correlates with patency. So if you do a bypass in a patient that needs flow, and you measure the index and it's less than 50%, something went wrong. Something went wrong. And that's associated with poor patency rate and failure rate of the bypass. We published that twice. Okay. Choice of bypass conduit. You go to meetings and you hear people talking about high flow and low flow bypass, but they do that by confusing flow with the size of the vessel or the name of the vessel. So for example, people would say low flow bypass STA, high flow bypass radial artery or vein. This is nonsense. Be very, very careful with this. There's no guarantee that the size of the vessel means flow. And I'm going to show you this, and this is a very, very important another point. Okay, so do not confuse the name of the vessel with the flow of the vessel. It's like looking at a highway, it's a big highway, and say there are 2,000 cars per hour that are going through this highway just because it's a 6-lane highway. No, it could be one car, or it could be 2,000 cars, or it could be 10,000 cars. Okay, so it depends on the traffic of this highway. It's not the size of the highway. Okay. So why is that? Why does size and a bypass not correlate with flow? Why did I say this? Because what is the most important determinant of flow in a bypass in vivo? Okay, I know what you're thinking. I know it because I show this equation and everybody says it's the diameter because that's Poiseuille's equation. That is generally true, but not in bypass surgery. In bypass surgery, the most important determinant of flow is the pressure gradient. That doesn't mean you measure pressure instead of flow. That's not a good idea, okay? Don't do that. That's not what I mean. People got confused and now they say measure pressure. No, flow is important, but flow is driven by a pressure gradient from point A to point B. That's the most important determinant of flow. And now to construct your bypass, you want to achieve the desired flow on one hand of the balance, while minimizing surgical trauma, selecting the graft that has the longer longevity. For example, a native vessel is better than a free graft, and you want to meet the hemodynamic requirement. That's the balance. Okay, so for example, look at the bypass on the right, on the left. It's an STA graft, looks good, and the flow is 79. The carotid was occluded. When the carotid reopened, the flow in the graft went down, the bypass shrunk, and there's a reciprocal relationship between supply and demand. So bypass can fail when there is no demand, and that's what we call a type 1 failure. And the other type 2 failures are due to technical problem, either with the donor, the anastomosis, that's the most common problem. That's why you have to practice, or the recipient, and that's moya moya. So I'm going to show you examples of that. Type 1 problem, no demand. Please pay attention to this. What you're going to learn here is something incredible. Okay, watch this. This is STA in red, bypass to SCA, superior cerebellar artery. Okay, look at the flow in the STA. First, we don't measure flow, it's 0. Then here, you see that here? I'm measuring the flow with the artery in the scalp. It's still in the scalp. I have not cut it yet. How much is the flow? 2, maybe 3, maybe 4. Okay? And all of a sudden, the same vessel goes from 234 to 65. What miracle just happened? How could that be? How could a vessel flow go, the same vessel, from 2 to 65? Did the diameter increase? No. What happened? This is the cut flow. You see how important it is? Here, there's a lot of resistance. The pressure gradient is very small. Here, there's 0 resistance distally, and the pressure gradient is high. The exact same vessel. And then after we do the anastomosis, the flow is very low. And this is a bypass done for ischemia. And this is a bypass where, if you look at the index here is about 5 of 65. So it's less than 10%. Very little flow in this bypass. No flow augmentation whatsoever. Type 1 problem. The patient did not need it. Okay? Please reflect on that. That's very, very important, especially when you do a bypass for aneurysms. The bypass for aneurysm is flow replacement bypass. What does that mean? That means you create a deficit and you replace it. So how much flow you have to replace? It's very simple. What kind of bypass you have to do is very simple. Calculate the deficit, measure the cut flow, and then construct your operation accordingly. There's different steps. You can read the papers that we wrote about that. So for example, here's how it works. That's a large aneurysm. You're going to sacrifice the carotid. So what is the vessel at risk? The MCA. Put a temporary clip on the carotid, measure the flow in the MCA, and you see that the flow dropped from 70 to 50. So there is a deficit, right? The deficit is how much? 20 cc's. What vessel to use? High flow, low flow, ridiculous. Measure the flow. So the cut flow of this STA is 44. That means it's enough. You see, because the deficit is 20, it can give you 44. That's all you need. You don't have to get a radial. You don't have to get a vein. You don't have to think, is it enough? It's not enough. You know for sure. And here's the important slide here, because in this slide, let me show it to you again. In this slide, you're going to see what happens in an algorithmic fashion with this bypass. So when you do this and you measure flow, you're going to get to this point here where you've done everything. And here's the summary. Okay, baseline flow is 70. You clamp the carotid, it goes to 50. That means there is a deficit. See, if there is no deficit, you don't even need a bypass. Don't waste your time. Now, you could do a bypass, but you don't need it, okay? So we got to replace 20 cc's. We look at the most simple thing. Take the STA, cut it. If it can give you 20 cc's, that's enough. So in this case, the STA gives 44 cc's. But what if you measured flow and it's only 10 cc's? You see, don't take a chance. Measure the flow. In this case, it's enough. We do the bypass. The bypass flow is 4. Wait a minute. What happened? You check the anastomosis, everything is good. Why? Because type 1 problem. There's no demand yet. But when you create the demand by closing the carotid again you create the deficit. What was the deficit? 20 cc's. What's the flow in the bypass? 24 cc's. You see, flow replacement. That's how it works. Okay. So what is this here? Look at this aneurysm. It used to be like this, big M1 aneurysm, and it became even bigger. It became a giant M1 aneurysm, huge. Okay, so people said, oh, we want you to do a high flow bypass. Nonsense. What does that mean? High flow means nothing. It's flow replacement. You have to measure the flow and replace it. So we measure the flow. How did we measure it here? Before surgery, actually, we measured it. We measure flow with the M1, with the MR. We have a software that we developed called Nova, and you can measure flow before surgery. So we have 32 cc's. That's all we need. 32 cc's. That's not high flow. That's not low flow. That's not middle flow. I don't care what it is. It's 32 cc's. The name of this flow is 32 cc's. It's not high flow. It's not low flow. That's meaningless. Okay. So STA, we check the cut flow. It was sufficient. So I do a very simple STA to MCA bypass, and we occlude the M1. That's all. And look at that. The aneurysm disappeared. It's gone. See that? It shrunk. It disappeared over time. And how much flow is in this bypass? We're measuring it with the Nova flow. The flow in this bypass is 18 cc's only. Why did the patient not have a stroke? Only 18 cc's MCA bypass. Why? Because look at the ACA flow, 116 cc's. Normally the ACA is 30. You see? So you have 80, 90 cc's extra flow through the ACA, PL collateral, and you have 90 plus about 20. You have almost 100, 110 cc's extra flow. That's why the patient has enough collateral. You understand? So why would you want to put a big vein graft or radial artery when you don't need it? That's flow replacement. Okay. Now, is there a role for large diameter conduit bypass? Remember, I didn't say high flow. I say large diameter. Sometimes you don't have a choice. Sometimes you have to use an artery, a vein. Like in this case, there was no STA. Look at this graft. It's 8 millimeter. So this is a large diameter conduit. It's an 8 millimeter bypass right now. Okay, we do the bypass. We're done. And we connect it to the carotid. And now the bypass is connected to the carotid. This is huge. How much flow? It should be high flow, right? How much flow? 24 cc's. That's not a lot of flow, right? Why? No demand, exactly. There was no demand. Look at that, 24 cc's. It's stopping with every heartbeat. Okay, so what do? We're gonna narrow the carotid and see what happens. Now we're starting to create a demand. The flow doubles by narrowing the carotid. What do we do next? We clamp the carotid completely. And what happens again? See, I'm clamping the carotid. And the flow now, included proximally and distally, so the aneurysm is trapped, it doubled again. So 83, so went from 20 to 50 to 80. And then after we finish, a few days later, we check the flow, 160 cc. Same vessel, but when you create the demand, there's more flow, you see? So, all right, last is the 2C problem, which is the recipient. So that's a common problem for Moya Moya. Again, look at this. That's an STA-MCA bypass. Cut flow is 150. Bypass flow is 149. So 98% flow. So that's an excellent bypass. Everything is good. Same thing. Very good bypass, but the index is 27%. That's what you see very commonly in Moya Moya. Why? Because in Moya Moya, the territories don't communicate. So the MCA is usually occluded and the bifurcation is occluded. You put a bypass on the temporal side, it doesn't go into too many branches. So that's why in Moya Moya, people, if you do a direct bypass, people want to revascularize as many territories and compartments as needed. That's why you see double barrel and etc. You can do all that, but I'm just gonna show you what we did to correct for this problem, the 2C problem in Moya Moya, which is the single vessel double anastomosis for 1V2A, SVDA or 1V2A. I showed this many years ago, and that's how you do it. So you can do the same thing you want to do, but using only one vessel and do 2 anastomoses. So you take the vessel and then you check the cut flow. If the cut flow is good right here, 100 plus cc's, that's excellent. Then you do 1 side-to-side anastomosis and you see the flow is 67. Then you do an end-to-side anastomosis on the other side of the sylvian fissure. So end-to-side and side-to-side, and you get 67 plus 40, and you get a full index of 1, okay? And you see the flow here, 140. So it allows you to do all those things. So these are the rules for Moya Moya. You got to keep in mind that it's a progressive disease, and no matter how good you are, if you do a bypass and you follow your patients over time, a lot of time the direct bypass involutes. So if you want to directly revascularize, you want to revascularize as many territories as you can. You want to use as much of this bypass as possible, meaning you're going to get a cut flow index as close to 1 as possible. So to do that, you do as 2 anastomoses instead of 1. And this way you minimize trauma. And the last thing is avoid disrupting collaterals. So preserve the dura. So you can do side to side, end to side, around the dura, keep the middle meningeal vessels, well preserved. And if you want to see videos of this, we published that in the literature. There's a nice 2D and 3D videos online about this bypass that we did in 2017. Okay, that's the summary of the SVDA or 1V2A or Minimax. All right, the last thing I want to talk about is a little bit philosophical. These are not easy surgeries, and the indications are difficult. They're rare. Sometimes they work, sometimes they don't work. And there's a lot of young people in the audience. And how do you keep your motivation in the face of failure? The most important thing I want to tell you, this is why it's important to measure data. is you want to understand if the bad result, bad outcome here, is because your process was good, you did everything right, but there was a bad break, or sometimes you did something wrong and deservedly the outcome was bad. You see, sometimes the outcome could be good because it was just pure luck. See, so when we fail, and we do fail, it's very important to go back and examine process versus outcome. Don't confuse the two, okay? And the best piece of advice I will tell you is this. I have it framed in my office back there. If you look back there, you'll see there's a frame and it's written there. For those of you that speak Arabic, this is what it says. اعلم أن الدهر يومان. يوما لك واليوما عليك. فإن كان لك لا تبتر وإن كان عليك فلا تضجر فأصبر فكلاهما سينحسر. Okay, in translation in English, life is 2 days, one for you, one against you. Okay, if you remember that, when you succeed, don't become arrogant. And when you fail, be patient and learn. And eventually everything will pass. Okay, so thank you, Fahd, my dear friend, President El Abadi, and it's a pleasure being with you today.
Thank you so much, Professor Fadi Shabel. I really like this last slide, and all the talk is amazing, and we need a lot of motivation in neurosurgery, and hearing your talk is just inspiring. Thank you so much. I don't know how you can deal with all this surgery, science, research, but we know that you are a person that wanna share all his knowledge with everyone. And I invite all people here, participants, to ask as many questions as they can. If they don't have questions right now, they can send it to Professor Fadi Shabel directly, and for sure he will answer to all questions, no doubt.
Happy to.
Thank you so much.
Thank you and congratulations.
Thank you so much. Is there any comments from the faculty here or the participants? I know that it's not that easy to talk about bypass. Maybe we will have many questions tomorrow when you are practicing this, and will ask question, and I will ask them to send you emails, because I'm not that clever to answer these questions. Okay, the next talk will be the talk of Professor Abedi. Unfortunately, she's a little bit tired, and she will give this talk tomorrow for sure. So we will move to the next speaker, our professor and dear colleague, head of the Department of Neurosurgery in Marrakesh, Professor Said Ains Ben Ali, a pioneer of the neurosurgery in Morocco, in Africa, and it will be and his talk about an important approach that we use every day, everywhere in every neurosurgical department, the retrosigmoid approach, with its special position and also special indication and especially difficult indication, difficult pathologies to manage. So, Professor Said Meli, thank you for accepting our invitation. You say every time yes to every invitation to share your experience with young colleagues, and in every activity that we organize at Abul Qasis University or at the Moroccan Society of Neurosurgery worldwide, and on behalf of organizer and upsurgeon and WFNS Neurosurgeon Award Committee, I want to thank all faculty for accepting our invitation. And Professor Said Al-Misbali, the floor is yours. Thank you.
Hello, Dr. Fahd, do you see my screen?
Yeah, very well. Thank you.
Hello, everybody. Thank you very much, Professor Labadi, Professor Nicolosi, and my dear friend, Dr. Fahd, for the invitation. And I would like to thank all the previous speakers for their brilliant presentation, Professor Fadi Charbel, Professor Kipar, Professor Sanzato, and Professor El-Wahabi. I will talk about retrosigmoid approach. The retrosigmoid approach is a lateral approach to the posterior fossa compartment. The retromastoid craniotomy is the workhorse of infratemporal approaches reaching several areas in the posterior fossa. The ipsilateral surface of the cerebellar hemisphere, the posterior surface of the petrous bone, the cisternal space defined as a cerebellopontine angle, and the ventrolateral brainstem. One of the main characteristics of this approach is that it's a very versatile approach. Of course, all these landmarks, this anatomy, bony landmarks, posterior fossa and brainstem, cerebellum, etc. We have to be very careful and to know very well this surgical anatomy, especially in this case of CP angle, dura, the cranial nerves, the veins, the vessels, brainstems, cerebellum, cistern, veins, cistern, cranial nerves, etc. It's very, very important to know this before practicing this kind of surgery. This slide focuses on the CP angle, and we have the resident have to know some landmarks: cerebellum mesencephalic fissure, cerebellopontine fissure, superior limb, cerebellopontine fissure, lower limb, petrosal fissure, and cerebellar medullary fissure, and the cranial nerves 9, 10, 11, 7, 8. Pons, medulla, pontum medullary sulcus, and focusing more on this CP angle, we have here some foramen and some very important landmarks, especially internal acoustic meatus with the 7 and 8 nerves. You have here the 5 and the Meckel's calf, the 3, 4, Dorelus canal with the 6 nerves, foramen jugulaire 9, 10, 11, and epiglossal canal, where past the 12th nerve, and sigmoid sinus, of course. One of the characteristics of the posterior fossa is this rules of 3. In the brainstem, vous avez 3 parts: midbrain, pons, medulla, cerebellar surfaces, and related surgical approaches. You have tentorial supracerebellar approach, infratentorial approach, petrosal approach, lateral suboccipital approach, and finally suboccipital approach. There are three phases and 3 main approaches. We have 3 cerebellar peduncles, superior, middle, and inferior. We have also 3 cerebellar brainstem fissure. We discussed them previously. We have the arteries, superior cerebellar artery, and ICA and PICA, and finally 3 groups of veins. The principal indication of this approach, retrosigmoid approach, are oncology, like vestibular schwannoma, meningioma, epidermolysis, or others, aneurysm also, vertebral artery, PICA aneurysms, or some cases of functional neurosurgery, MVD, microvascular decompression for the 5th or 7th nerves. There are several alternative procedures, but today I will focus on the retrosigmoid approach. I will not detail this approach because of it's not our subject today. This approach has many advantages. The approach affords the simplest access to the CP angle and lateral clavus. The approach is extremely versatile and can be tailored according to the pathology which must be treated. And the approach can be extended upward or downward if supratentorial or craniovertebral junction exposure is required. The main inconvenience of this approach is sometimes we have to face and to work in some narrow corridors, and we need some experience in order to achieve this surgery without damaging the vessels and the nerves in the CP angle. We have also adopted the principle of retractor surgery and avoid to retract cerebellum. And we have to pay attention to the cranial nerve and vascular element in this area. About equipment, we need the MyField. The main equipment for this surgery, I think, is a microscope. Very important. An endoscope is optional. We need, of course, a craniotome, speed drill, bipolar, Yazarji retractor, micro instruments, and IONM, intraoperative neuromonitoring. If we have it, we use it. If not, we can do this surgery without. But it's a very useful equipment to achieve this kind of surgery. We need, of course, some consumable hemostatic agent, hexacyl glue, bone substitute, dura matter substitute, Teflons, clip, and for some patients to do an EVD, extraventricular drainage. Informed consent is very crucial for this surgery about procedure, alternatives, and complications. We need a multidisciplinary meeting with especially autonologic and anesthetic assessments. And IONM, if we have it, ACP, MEP, AMG, brain auditory evocative recording, and of course, to stay in ICU for this kind of patient is mandatory. We need also to check some bony anomalies, bony assessment, especially mastoid cells. It's very important. And analyze very well MRI. And for some patients, we need pre-embolization for some kind of pathology. Here you see a checklist for every surgery. Every surgeon or resident have to know this checklist with different steps before induction and anesthesia, before skin incision, and before patient leaves operating room. This is for every surgery. About this approach, the position can be lateral or park bench or semi-sitting, as illustrated in this slide. About position, the MyField scalp clamp is positioned with the single pin on the side of surgery, anterior to the tip of the ear, outside of the operator's working zone. The head of the patient is slightly flexed and turned toward the floor. The operative area must be into horizontal plane, and careful attention should be paid to the neck position. Very important. Excessive rotation and flexion, not avoid jugular vein compression that may compromise venous return. The patient's ipsilateral shoulder can be moved forward, and in order to have a very good surgical field. The patient should be secured, of course, on the operating table, and we have to prepare for some fat or fascia harvest. This position is illustrated in this slide. As you all know this. The previous speakers speaks on that landmark of skin incision. Some surgeon use semi-sitting position. The incision is linear with some landmarks. The main landmarks is a mastoid tip. The starting point, incision starts 2 centimeters behind the external ear at the level of the spina. The coarse incision line runs inferiorly to the stripe line, and the point 1 centimeter inferior to the mastoid tip. There is several types of incision. As illustrated in this slide, you have here a transverse sinus, sigmoid sinus, location of craniotomy, incision, inion. About soft tissue dissection, we need to do a subperiosteal dissection. Muscles are incised according to the skin incision. periosteal dissection is carried out laterally and medially. And we have to be very careful about some critical structure at, for example, vertebral artery at the atlanto-occipital junction, and sometimes must with emissary vein, which can bleed during this surgery. Craniotomy, we do a burr hole in the asterion, and there is some landmarks as illustrated in this slide, and we have to pay attention, as I said previously, about some critical structure, and this look near the sinus we have to use a drill and to avoid the sinus injury. There is some variation of this approach. We can do this for MVD for trigeminal neuralgia, for example. We can do this. We can do this green, and we have sometimes a lot of veins, as you see here in this picture. The same. You all know this. Near the sinus, we have to use the drill, or sometimes you can also use the Kerisson to make a good exposition and to go straight forward to the CP angle and to avoid some cerebellar retraction, which can lead to the infarction or some hemorrhage. About dural incision, we can use a C-shaped incision. Dura mater is opened along the sigmoid and transverse sinuses, which are reflected anteriorly and superiorly, respectively. And we again have to be attention about these veins, these sinuses, and to avoid their injury. Intradural exposure, we see all the structure in the posterior fossa: parenchymal structure, petrosal cerebellar surface, flocculus, choroid plexus, and brainstem. Arachnoid layer, we have to open the lateromesencephalomedullary cistern. We see all the nerves: 5, 7, 6, 7, 8, 9, 10, 11, 12, arteries, ICA, cerebellar artery, veins. One thing is very important: the cerebellum should be retracted dynamically, only parallel to the direction of cranial nerve 5 and 9, to avoid direct traction on the cranial nerve 8, which can lead to some hearing loss for these patients. This technique is illustrated in this slide. We start by opening the lower cistern and to release some CSF and to get some to obtain some simple cerebellar relaxation. We see the vertebral artery, the cranial nerve, lower cranial nerve, and 7, 8, and up the surgical field, the 5th, the tentorium, the vein, superior petrosal sinus, superior petrosal vein. We focus on this area. We can see very well this vein, and during surgery we have to be very careful, because sometimes when injuries these veins, it bleeds, and there is some brain infarction and some difficulties during the operative surgery. There is several corridors. It depends on the location of the pathology. For example, MVD for trigeminal neuralgia, we have to work at this part of the CP angle. For hemifacial spasm, for example, for acoustic neuroma or for epidermolysis, we have to work at this area, and to extend this approach regarding the size of the lesion. And for lower part, you have this lower cranial nerve, vertebral artery, la pica, and we can recognize all these structures. About closure, closure is made by continuous running suture. We need absolutely a watertight closure by using fibrin glue, and opened air cells are closed with muscle or fibrin glue. The dura is covered by gel foam. In case of craniotomy, the bone flap is reinserted and fixed with the plates if we have it. The bone defect due to the craniectomy, but because we can do the craniotomy or the craniectomy is closed with metagranite if we have it also. The wound is closed in layer finally. as illustrated in this slide. We have to remember some pillars about this approach. It's very, very important. Bleeding from emissary veins can be controlled by hemostatic agent and bone wax. Spiking or large amount of bone wax must be avoided. Why? Because due to the risk of the sinus thrombosis. Sinus bleeding can be controlled by a patch of muscle or suture. Starting the intradural procedure by opening the cerebellomedullary cistern to release some cerebrospinal fluid, usually provide a good cerebral relaxation. Closure and any opened mastoid cell air cells with muscle and fibrin glow at the end of the surgery is important to prevent postoperative leakage of cerebrospinal fluid. During the postoperative period, antibiotics are administered for 24 or 48 hours. Observe for CSF renuria or CSF leakage from skin. Monitor, it's very important, monitor for hydrocephalus. For patients, for example, who have a large tumor, we can do previously ETV and surgery later, or we can do extradural drainage, or for some in some circumstances in V patient. Monitor for hydrocephalus or hemorrhage or edema of the brainstem, and we continue also steroids. We can face some complications during the perioperative period. Injury of the cranial nerve, 5 to 11 because excessive retraction and manipulation. Vascular injury, HICA, labyrinthine artery, PICA, internal auditory artery, sigmoid sinus, superior petrosa sinus, or petrosa vein. We can also have face some mechanical brain injury from prolonged or excessive retraction. Hematoma may occur in the brainstem, cerebellum, or subdural and extradural space with devastating consequences if unrecognized. It's very, very important. During the postoperative period, we can also have some facial paralysis or sensory deficit from cranial nerve, excessive leak leading to meningitis of pseudomeningocele, dysphagia related to the lower cranial nerve injury and pneumonia, intracranial abscess, ischemic or hemorrhagic brain stem stroke due to the arterial or venous or sinus lesion. For some patients, ataxia from cerebral edema. Now I will present some cases to illustrate this approach, some cases in our department, in our practice, daily practice. This lady was in our department for this acoustic schwannoma. We operated her by performing a retrosigmoid approach. This is, I will show you some videos. Right CP angle approach. We understand step by step the anatomy, and we use the sharp dissection to avoid a lot of retraction and to dissect the lesion from the vascular nervous structure in this location. We release some CSF leak. I can advance slightly the video. For some patients, we use ultrasonic bisturi. For others, now it depends on the equipment. For this kind of surgery, we operate also the patients, some patients by using intraoperative neuromonitoring. Here we can debulk gently the tumor from the medial part with dissection from the brainstem. And we proceed to debulk the tumor to reduce the volume and allow us to dissect the capsula. You see here in white brainstem, we dissect the tumor from the pons. We use regularly some irrigation, saline, and we perform the hemostasis. This is another patient admitted in our department for acoustic neuroma. This is her MRI. We operate her by using intraoperative neuromonitoring with our neurophysiologist, Professor Shrah. We did a gross total removal of this lesion. Another patient, a huge acoustic neuroma, we operate her also. We did a gross total removal of the tumor. This is the patient during postoperative period with mild facial deficit. This is another patient who operated also in our department. We did a gross total removal of this lesion without facial deficit. This photograph is taken during the postoperative period. This is another patient with the cystic part of the tumor, which facilitates the approach for this for resection of this tumor. We did a gross total removal of the lesion. This is his postoperative MRI without residue. Another patient also, we operated him for this acoustic neuroma. This is his postoperative MRI with mild facial deficit because he recovered after by using some physiotherapy. This is there is some postoperative aspects of the surgical field. Another patient also in our series. This is operated. This is a postoperative CT scan with good resection. Another patient also with the good resection. Another patient. In our department, our policy is to try to do, when possible, of course, to do a gross total removal of this lesion if possible. This is the postoperative CT scan with the gross total removal of the lesion. Another case, this patient was treated previously by gamma knife radiosurgery without surgery. I don't know why. He comes to our department. We operated him with. You see here some edema and a lot of edema in the cerebellum. This patient underwent gross total removal of the lesion, but he's still now in ICU, in intubated and with pneumopathy. It's a very difficult case. Another patient also. This is a preoperative MRI. This is postoperative CT scan, a good resection. Sometimes we can face the patient with the bilateral lesion, like in neurofibromatosis. This kind of patients is very, very difficult to manage, and we can sometimes do an approach in one side and to reduce the lesion. But I don't know what think all the faculty members about management of these difficult cases. We present another type of this pathology in this area in our department. This patient was admitted for epidermoid cyst with facial deficit and hearing loss and some dizziness. We operated him, and we do also a gross total removal of this lesion. This is the approach, retrosigmoid approach. We proceed to the gentle cerebellar retraction. We recognize lower cranial nerves. We open the cistern and we release some CSF leak. We start to remove this lesion by aspiration, resection. It's not very difficult surgery, but we have to be very careful about the nerves and the vessels and avoid a lot of retraction. We debulk, we aspirate this lesion, the classic epidermoid cyst. We use several corridors above, below the cranial nerves, step by step to make a resection, a large resection of this patient. For this case, we used at the end of surgery also the endoscope to check the corridor and some part which cannot be seen by microscope. We release the vertebral artery. You say the lower part, lower cranial nerve. You say the vertebral artery. So step by step, you say the basilar trunk here. We can say the upper part, the upper part of the lesion. And basilar, you see the basilar trunk. And for this patient, we use at the end the endoscope to check if there is a remnant in the upper part. And we use alternatively microscope and the endoscope. You see the vertebral artery, the basilar trunk, lower cranial nerve. We use again the microscope. No, this endoscope. After using the microscope, we check again by the endoscope, and the pulse is free. And you stay here the superior cerebellar artery. This is his postoperative CT scan, and the patient did well, very well during postoperative course. Sometimes we use also this retrosegmental approach for some biopsies of brainstem glioma, like in this patient. We use this approach to perform a biopsy and to send the patient later in the oncology department. I will present another type of pathology, trigeminal neuralgia. A patient who admitted in our department with refractory trigeminal neuralgia due to vascular nervous conflict. We approach the CP angle. We dissect different. We use the sharp dissection and to make vessels and nerves free, step by step. Sometimes we can sacrifice some veins in order to have a large corridor and to continue the dissection. And we understand step by step the anatomy of the patient. Sometimes for this kind of surgery it's not very clear, but step by step we can understand, and we can sometimes cauterize some veins. I will advance the video. You see here the trigeminal nerve, and you have you see a vein, an artery, and you try to make free the nerve, and to put some Teflon or some surgical between the nerve and the vessel. Another case, trigeminal neuralgia with vascular conflict, as you see here. This is sometimes we use my field, but sometimes also we can operate without using it. There are the landmarks for the craniotomy. The sinus here. I'm totally agree with Professor Fadi Charbel. Me also in this kind of surgery, I don't use a lot of instruments. I use only 3-4 instruments. I hope spatula, microscissor, cotton, bipolar, and microscope, of course. Finally, I present this case also. A lady who was admitted in our department for a ruptured right vertebral artery aneurysm with the lower cranial nerve deficit, as you see here in this angiogram. We operate her, and by using the retrosegmental approach. This is medulla, this is the vertebral artery, this is the aneurysm, there are the lower cranial nerves. So we can clip this aneurysm without a lot of difficulties. She did very well during post-operative period. In conclusion, I can say that the retrocyclomid approach is a very flexible and versatile approach, workhorse approch. We care for preoperative workup can avoid or reduce the risk of intraoperative difficulties, sharp dissection, sharp arachnoid dissection, and strategic dynamic cerebellar retraction will facilitate cerebellar mobilization without placing the cranial nerve at risk. And thank you very much. Thank you for listening.
Thank you so much, Professor Aizben Ali, for this wonderful talk. I'm sure that all participants enjoyed this talk and learned a lot from your experience. Thank you so much. I don't know if there is some questions. You can also send this question by writing them on the discussion part, and we will move to the last but not least speaker, my dear friend and colleague, Professor Boutarbosh Mahjouba. She's the neurosurgeon that could mix between endovascular and neurosurgical procedures for many patients, and with a lot of experience in vascular surgery, especially in endovascular. I have the pleasure to meet her when I was a resident. We worked together many years, and today she will talk about another topic, not vascular, but skull-based surgery, the temporal bone approach, which is a non-porous approach for a neurosurgeon. And just to say that Professor Boutarbosh is professor of neurosurgery and anatomy at the Department of Neurosurgery at the Hôpital de Spécialité, and also professor of anatomy at the Med School of Rabat, Mohammed V University. So, Mahjouba, the floor is yours. Thank you for accepting our invitation and for joining the pedagogic team of this workshop. And on behalf of Professor Abedi and all the team, thank you so much. The floor is yours.
Thank you very much, dear friend Fahd. It is such a pleasure to join the faculty in Abul Qasis University for this very interesting skull-based and vascular workshop with this new technology that we are going to, for me to try and to meet for the first time tomorrow. It is also such a pleasure to have the opportunity to thank Professor Abedi and yourself, Fahd, and all the staff of the neurosurgery team in Hôpital Sheikh Zayed for this opportunity to meet with such an amazing faculty and to listen to such an interesting topics with Professor Abedi, without whom I would not be interested. I wouldn't have been so easy going in neurosurgery, because she was truly the leader in women in neurosurgery in Morocco, and we thank her very much for all what she's doing. We only come to a real appreciation when we have been there in this path after almost 20 years, which is my case and the case also of Muna and many others around. So allow me now to share my screen and to start with sharing some of what I prepared for you about the temporal bone approaches. So to begin, the temporal bone is a dense, complex bone. It is complex because of the 3D relationships that it has between the neurovascular structures inside and around. The petrous portion of temporal bone is has a role as the partition between the middle and the posterior cranial fossa. It articulates with the occipital bone posteriorly, the parietal bone superiorly, and the sphenoidal bone here anteriorly, and the zygomatic bone here, and the mandible through the temporomandibular joint inferiorly. In an overview of the skull base, here is the temporal bone. It has a squamous part, but it has also this petrous part that is like a rock. But inside this rock, we have so many interesting and important neurovascular structures. Also, we have the tympanic bone, and we have the styloid process and the mastoid process. Very complicated one. So let's have a look and try to remind some of the superficial landmarks of the squamous portion. Here is the temporal fossa. Here is the suprameatal crest. Here is a temporal line. Here is the external acoustic meatus. Here is the McEwen's triangle, the suprameatal triangle, safe zone. Here is the trajectory of the middle temporal artery. Here is the squamomastoid suture, and here is the mandibular fossa that articulates with the mandible. Here is the articular eminence. Here is the zygomatic process that we can sometimes take out to have a better access. Here is the pinterotympanic fissure, and here is the mastoid foramen, just for a vein, a small vein. Here is the parietal notch, and here is the mastoid with cells inside and antrum. And here is the mastoid notch, also called the digastric fossa, that has been showed as a landmark for the retrosigmoid approach. Here is the occipital sulcus, and here is the tympanomastoid suture, and here is a vaginal process, and here is the styloid process. Now, here is the petrous pyramid. The petrous pyramid is a dense rocher, is a dense pyramid-shaped bone and composed of the labyrinth of the internal ear, the tympanic cavity of the middle ear, and the bony part of the auditory eustachian tube, and the canals for the passage of the internal carotid artery and the facial nerve. Here is the medial aspect where we can see the petrous ridge. Here is the accurate eminence. Here is the internal acoustic meatus. Here is a subarcuate fossa. Here is the aqueductus vestibuli. And here is the sigmoid sinus sulcus. And again, the mastoid foramen, the styloid. And as you may have recalled, the internal auditory canal has this superposition of, in this order, of the facial canal besides the superior vestibular area, and then the inferior vestibular area, and then the tractus spiralis foraminus. This is the fundus of the internal meatus. Here is the inferior surface of the petrous portion, and we can see here the fossa mandibularis for the mandible, styloid process, and the foramen, the styloid foramen, the eustachian tube here, the internal opening of the carotid canal, and here the external opening of the carotid canal. So we can guess here really the petrous canal of the ICA, and here the star is for the inferior tympanic canaliculus and the cochlear aqueducts. Here is the structures of the petrous portion. Here we can see, when you see, this is the foramen magnum, and this is the petrous bone. This is the trigeminal nerve and its branches. One is going through the orbital fissure, as you may recall. This is the optic canal. This is the anterior clinoid process. This is left, by the way. This is the foramen rotundum, and this is the foramen ovale that we can drill when we are going to do middle fossa exposure for a quasi approach, as a matter of fact. There is the internal opening of the carotid canal. There is the eustachian tube. There is the cochlea. There is the middle ear. There is the mastoid antrum. There is the external auditory meatus, and here is the internal auditory meatus, and entering the nerves. So 7, 8, and here is the foramen jugulare with the the nerves, glossopharyngeal, vagus, and spinal. And here is the semicircular canals here, so virtual, of course. And as you may recall, with the exposition of the whole endocranium, here is the sella, and here is the petrous ridge. Here is the temporal fossa. Here is the posterior fossa. Here is the anterior fossa. So if we are now talking about this bone and the approaches through the temporal bone, it's mainly because we want to have an access not only to the middle fossa, but from the middle fossa to a perspective to the posterior fossa mainly, but mainly to the clival region with the very deep-seated lesions. Here is again an exocranium view where we can see zygomatic arch, the foramen ovale, the foramen lacerum, or the external opening is here. This is the external opening of the carotid canal. This is the foramen lacerum, and we can see also the mastoid here and the condyle here, just to remind the situation. But you have to know that it's not only the bones. It's not only the bones. The bone is covered by the dura. So we have the dura that is covering all the skull base. If you want to, of course, if you want to discover these neurovascular structures, you have to open the dura and you have to drill some of the bony structures to get there. So actually, you have this dura covering the anterior and the middle fossa, and the tentorium that is covering the posterior fossa. So this is the middle fossa, and this is what we want to see through the transtemporal approaches. And this is the number one approach, the anterior petrous approach, through which we can access to many lesions. So let's start with the anterior transpetrosal approach. The anterior transpetrosal approach can allow us to get to basilar artery aneurysm, to petroclival meningiomas, to skull base chordomas, to pontine cavernous malformation, to some cerebellar, superior cerebellar artery aneurysms, and some cholesterol granulomas, also some schwannomas, Meckel-Kev schwannomas, cavernous sinus meningiomas, etc. Is to say This is to say that for the very difficult cases in a neurosurgery, this approach can add value, is a light. It's like a light in a tunnel, and this is not for the easy, let's say the easy, not easy. Nothing is easy, but it's for the more difficult cases in neurosurgery, actually. So this is after. This is the middle fossa exposure of temporal bone. This is a superlateral view with the tentorium removed, but the edge. Dura is removed from the floor of the middle fossa, and what we can access to is the wall of the cavernous sinus. Here is the ophthalmic, here is the maxillar, superior maxillar, and here is the mandibular. Here is the trigeminal nerves, as you see, and that is what you uncover when you open the dura, and you expose also the great petrosal nerves and the middle meningeal artery and a lot of cranial nerves. Let's go step by step and see what we can uncover. This is also what the anterior petrosal approach gives you access to. Give you access to the cranial nerves with its branches, to the petroscarotid artery, sometimes in some anastomosis, gives you access to the cochlea, gives you access at first trochlear nerve, and then to the whole canals of the internal ear. Again, we can go very deep and we can observe all these structures using a drill, but a very thorough knowledge of anatomy. This is what we aim to see when we go for exposing the middle fossa of the temporal bone, and the aim is to access, especially to access the clivus here, that we can divide in four parts. The first part can be reached actually through a frontotemporal orbitozygomatic or subtemporal approach. The second, between the fifth and the eighth nerve, which is this region here, is mainly what we use the anterior petrosal or the Kawase approach. Okay, here between the fifth and the seventh and eighth. Here, this part is mainly accessed by the Kawase approach or the anterior petrosal approach. Third is lower of the temporal bone, and we need for this access to combine a posterior petrosal variant. And at the end, the fourth is below the jugular foramen, and we need for this a far lateral transcondylar approach. So the reality is that the anterior petrosal approach of Kawase is an extended middle fossa approach. It is really coming from a middle fossa perspective into the posterior fossa through the tentorium. So we want to see what's going on in deep in posterior fossa. We want to dissect deep-seated lesion in the posterior fossa, in the clivus, going through the middle fossa. That's how that's why we go through the petrous, and we have to use an extradural anterior petrosectomy and go and cut the tentorium and then get to the posterior fossa. And that's what we discover. The approach we get to the brainstem between the fifth here. Here is the cochlea, here is the semicircular canal, here is the basilar artery, here is the clivus, here is the brainstem with the nerves, here is the seventh, and here is the eighth. And petrous apex lesions, we can get cholesterol granulomas, chordomas, chondrosarcomas, and some upper petroclival meningiomas. In brainstem, we can get some anterolateral pontine cavernomas, upper also to mid-basilar aneurysms, and it allows the shortest distance to Meckel's cave. So when you open up the fibrous ring of the porous trigeminus, you get access to these regions of Meckel's cave, and you can move the Gasserian ganglion, just move it, anterior or posterior, and drill again. One of the major advantages is that you get this look back view into the brainstem. Open posterior cavernous sinus, short distance to Meckel's cave, and petroclival regions, Dorelow's canal, the sixth nerve, middle clivus area. This is the kind of lesion that you would want to access using a petrosal approach after having tried to remove it completely via a retrosigmoid approach. That's when you have some dead angles that you cannot control. This is where the petrosal anterior approach, when needed, of course, can be used. Especially if it is a meningioma or a schwannoma, one can say that we can use a gamma knife radiosurgery, but if it is an epidermoid cyst and with the facial paralysis or with the trigeminal neuralgia, then you would need to go and finish the job if you, of course, if you can. These are very difficult approaches that need a mastery, of course. So usually we go to the petrosal approach with combinations of frontotemporal or temporal craniotomies or orbitozygomatic or posterior petrosal. Usually it is combined. So at the beginning, the head positioning is better than about 30 degrees from horizontal, just to give better access to the petrous bone and a better drilling during the surgery. About the craniotomy, it's better if you can do a drop-down zygomatic osteotomy. This will give more inferotemporal fossa exposure for for this we would favor a larger skin incision because it gives a wider craniotomy and more angles, and it has the advantage of giving less lobe retraction, less temporal lobe retraction, as you may see here. And this is just one example. When you do a transzygomatic osteotomy, you definitely have not this crochet on your muscle. You have the muscle far away, so you can have a better access to this internal carotid artery, and you have less retraction on the temporal lobe. As seen here, you have a better corridor here with just a small retraction, while here you have a small corridor. So in reality, the exposure of the middle fossa at the beginning is done extradurally. So we just elevate the dura. We elevate the dura as seen here, and we expose the skull base. When you expose the skull base, the very important thing to do then for your Kawase approach or your anterior petrosal approach is what we call the middle fossa rhomboid, described by Fukushima. When you understand what is the middle fossa rhomboid, then you can drill safely, then you can identify the neurovascular structures you need. The middle fossa rhomboid, is this what you see here? Is this what you see here? It is a rhomboid shape, okay? And it is bordered by the back of the V3. Here is V1, here is V2, here is V3. Okay? This is the ovale, the foramen ovale. So the back of the V3 anteriorly, this is anterior, this is posterior, this is medial, this is lateral, this is your retractor, okay? So this is the back of V3 anteriorly. You have the great superficial petrous nerve laterally, and from the great superficial nerve laterally to the geniculate ganglion here, you have the arcuate eminence posteriorly in the bone and the medial petrous ridge medially. So you have a petrous ridge, remember, in the petrous bone. You have, we can see it again here. You have the V3, so the back of the V3. You have the great petrous nerve. You have superficial petrous nerve, GSPN. You have here the eminence, the arcuate eminence, and you have the ridge, the medial ridge. If you drop a diagonal from the angle of GSPN and the geniculate, the ganglion, and here the arcuate eminence, this you just draw a diagonal. And remember, this is V2, V3. This is the foramen spinosum that gives rise to the meningeal middle artery. Okay, this is great superficial petrous nerve, and you can identify the location roughly of where is the internal auditory canal going to the cochlea, and just behind, below the dura. So here is the landmarks. Here are the landmarks described. So at first we to drill and to discover, to uncover this. Here is the foramen spinosum. So where lies the middle meningeal artery that we should coagulate and divide. Then we start peeling. We have to peel the dura propria off the lateral wall of the cavernous sinus between the two layers of the dura, between the dura propria and the periosteal layer of the dura, to expose the V3 and the V2. Then we have a nice view of the middle fossa rhomboid. Lateral to this is Glasscock triangle, the region of the horizontal petrous internal carotid artery. Okay, so this is the petrous canal, the petrous carotid artery, internal carotid artery, and here is the horizontal ICA is here. JSPN is here, and then you have, as we bisect that angle and identify where the cochlea is, this gives us an idea of where the danger zones will be, so that we can begin the drilling without injuring neither the carotid artery or the inner ear. In reality, we have to have in mind a kind of a virtual reality view or an X-ray view or something like that. When we just retract the temporal lobe, we should just know exactly, or quasi exactly, where the horizontal petrous ICA is, where the cochlea is, where the facial nerve is, and the vestibular and semicircular canals are. So here is another drilling. Here is the drilling of the region and what we can, internal auditory canal, cochlea, the clivus is here, great superficial petrous nerve here, and the internal carotid artery is here. The arcuate eminence, which is a semicircular canal, is here. We are right here is the V3, our number one landmark that we can mobilize to drill. So what about the dura opening? We open the dura at the temporal base. We incise the posterior fossa dura. What is important is when we divide the tentorium, we must visualize one important nerve, which is the fourth. The fourth is very fragile and can be delacerated when, if we are not careful about this and about the traction that we can put on the layers of the dura. It is invested in a layer of arachnoid that gives some, in some extent, some protection. And then, as you may see here, the first vascular structure, venous structure that you encounter is the superior petrosal sinus that you can cut, divide using a bipolar or sutures or clips, and then you start dividing the dura either from medial to lateral or vice versa, or even a combination to get through the posterior fossa. Once you have opened the dura, you have a wide exposure to the brainstem, specifically between 5th nerve and 7th nerve. You also have great exposure between the fourth, here is the trochlear nerve, and the fifth, and also above the fourth. So you have different areas of the brainstem that you can access, especially if you have to deal with cavernomas. Here is the kind of lesions you can access and you can check out. This is the exact definition of petroclival meningioma. It is medial to the trigeminal nerve, so there is no chance you can access it sometimes if you don't go through this approach. So at the beginning, here is just to say that this, I cannot provide a video because this is not something that we usually do in a routine basis. We really had this done sometimes when we had some visitors. Remember, even when I just started my internship, we had Fukushima itself invited by Professor Khamnishi. Anyway, we don't do this in a routine basis, so I just follow the steps of dissection in some data collected here and there. So this is the first thing we start doing, is the division of the middle meningeal artery at the level of foramen spinosum. This is something residents do usually when they have extradural epidural hematomas. They have middle meningeal artery cut, and they have the extradural there, the hematoma, so they know how to go to the foramen spinosum. But these things, of course, are done under microscope. So first step, coagulation of MMA, and then pulling off the dura, pulling off little by little of the dura, and identifying of the GSPN, greater superficial petrosal nerve, then starting the decompression of the foramen ovale that we can see. It says just a kind of a hiatus. Foramen ovale is not like what we see in the schemes, that is real. We can then feel it and start drilling it and decompressing the foramen ovale. And then we can continue pulling off the dura until we have these whole structures. V3 can be even mobilized, GPSN, geniculate ganglion, articulate eminence, the medial, until we get to the medial petrous ridge. And here we can assume we have reached the internal auditory canal and the cochlea is right there. So we are going to deal with the anterior petrosectomy, which means we are going to work mainly in this region. So we continue the drilling of the anterior part after we have mobilized the V3 anteriorly, and then until we reach a nice opening, bone opening, and then we open the dura. At the time we want to open the dura, we have to be, as I said, very careful with the fourth nerve. Sometimes you face the tumor first, so you have to be very careful because the nerves are, so you have to start debulking and emptying the tumor from inside using CUSA or even bipolar shrinking until very of course very low temperature, so that you can not injure the nerves. Then the opening, when you finish the job, you have to repair. You can repair using many things. You can use, of course, the graft, you can use the epicranium at the end, you can use Duragen, etc., etc. But it's very important to, of course, to repair the dura in the skull base to avoid the problems known. Here is a dump shell schwannoma. This is typical image of trigeminal or Meckel's cave tumor that can be accessed through the Kawase approach. Here is again cholesterol granuloma, can be only accessed through this, to be completely removed only through this approach. Of course, we have also the posterior petrosal approach that is more known as the petrosal approach itself. It is a pre-sigmoid from a pre-sigmoid perspective. Here is the sigmoid sinus. We need to do a mastoidectomy with an L-shaped subtemporal craniotomy. We can go retrolab, labyrinthine. If we want hearing preservation, we can go pre-sigmoid transtentorial. We can do combined with other petrosectomy, and we can keep the otic capsule intact and drill the anterior petrosectomy with the retrolab posterior petrosectomy for hearing preservation. Anyway, this gives, when you combine these approaches, this gives a very well access to the structures in this area. Here is an example of the combination and what you can do if you want to reach some deep-seated lesions. So we have some variations of posterior petrosectomy, and these petrosectomies are tailored to cases. We have variable degrees of petrosal temporal removal to attend clival exposure. So for the middle fossa anterior petrosectomy, we have the pre-meatal triangle anterior to the internal auditory canal, or the post-meatal triangle posterior to the internal auditory canal. For the transmastoid and the posterior petrosectomy, we can use retrolab for hearing when we aim to hearing preservation, or translab when the hearing is already damaged. Of course, we can also use total petrosectomies in some cases and have very large exposure to the structures. So in conclusions, the transpetrosal approaches are important. They are truly difficult. They add to our available routes to deep-seated lesions, a light in a tunnel, like kind of a thing. They need, of course, a thorough knowledge of anatomy, a lot of training, a lot of patience, and practicing that would be, in my opinion, the next level of mastery, from a good professional to an amazing artist to a kind of a god. Thank you very much.
Thank you so much, Professor Butterbush, for your talk, amazing talk with a lot of information. We will have the opportunity to see all of these details tomorrow at the lab. Thank you, and thanks to all participants, to all faculty and all participants. I wonder if there is any question or remark. Let's go for a small test for all participants. I ask all participants to turn on their video, please, and okay, and let's go for a test, small test for this, for today. Okay, go ahead. So 9 questions about today's talks. All the workshop, this theoretical part will be on YouTube. You can review these talks again if you need it. I'm sure that you will need to review many of these talks to have more details, because we can't get all information in all details. But if we are looking for more information, you can go to the YouTube. The link is on the discussion part, and also you can ask your question directly to all speakers. It will be my pleasure to send all questions to our speakers. Waiting that you answer, I wanna thank all our faculty, Professor Fadi Charbel, Professor Marco Senzato, Professor Kipark, and Professor Federico Nicolosi, the National Faculty, and also National Faculty, Professor Aitzbenelli, Professor Wahabi, Professor Abedi, Dr. Bona Bugrin, Dr. Hamama, and Professor Hajuba Botarbouch for their kind participation. I want to thank my mentor, Professor Abedi. She's the one behind all of this activity. She showed us the way, and we are doing our best to follow her steps and to just create a good environment for sharing and learning. Thank you so much. I will stop this test and let's go for results. I will see the results with you in the same time. Did you see the results? Not yet. Well, I will get the results on the website tomorrow. I think that it doesn't work. Did you finish your answering or not yet? I will start it again. Please answer and confirm your answer by the end. Please do it again because I didn't have any answer. So I give you 1 minute, almost 30 seconds. So for tomorrow, we will start at 8:30, our workshop. You will take breakfast together and then start the practice on the monitor training, neighbor training, and also manual training. Tomorrow we will have Professor Hajoua Botarbouch, Dr. Mona Bougrine, Professor Hamama, Professor Abedi, and myself during this workshop. And you are welcome. Welcome to the university. It will be at the simulation lab in the university. It will be, indication will be put at the main entry to the university. So I will stop. Everyone had answered. I just have just few answers. Take the risk. You are a neurosurgeon. Enjoy taking some risks. Only five participants who answered. I can't know who answered. So we just wanna know how do you reach, how do you get information, and if you can follow us. 8 personnes qui ont répondu. C'est tout? 9, oui, déjà 9. Très bien. 9 participations. Qui dit mieux? Donc, on arrête la participation et puis donc là, on va faire... Ah, il y a déjà 11. Les gens insistent à répondre. Donc, faites vite.
Oui, attends un peu, faites, parce que les questions sont longues et les propositions, comme c'est en anglais, peut-être que ça...
D'accord.
Laisse encore une petite minute.
Grâce à Mouna Bougrine, grâce au Dr Bougrine, on va attendre un petit peu.
Et aussi, je pense que ça fait longtemps qu'on est concentré. Il est 20h.
Oui, aussi, oui. La première fois, tu avais fermé avant que je puisse soumettre.
D'accord. Donc, maintenant,
Le temps que je lise.
D'accord, super. Donc, vous voyez, même les facultés veulent répondre. Donc, j'invite tous les participants à répondre. On est 26, donc j'aimerais bien avoir 26 réponses. Et puis, je tiens à remercier mon cher maître qui ont été avec nous ici aujourd'hui. Et bienvenue aux participants demain.
Je vais vérifier ça que j'ai trouvé en ligne. C'est bon?
Donc, on a 12.
C'est une bonne moyenne.
12, d'accord. 13, très bien. Qui veut plus de temps? Sinon, si tout le monde a fini, on passe au résultat.
Je vois ceux qui ont leur vidéo, ils ont fini. Et que ceux qui ont déclenché.
Ok.
Je ne suis pas sûre. Non, peut-être qu'ils n'ont pas pris le test.
Aussi.
Voilà. Donc, what is the number of animate neurosurgeon operations around the world? Alors, 57% des 3 millions. Alors, ceux qui ont raison, c'est les 21%, 5 millions.
Ah ouais,
alors,
j'hésitais.
Donc, how many additional neurosurgeons are needed worldwide? The correct answer is 23,000, 36%. The main objective of the operating is to provide a basal and wide exposure of the avian feature. Is true or false? So 70% answer true is the correct question answer. And after opening the patient, the avian feature dipterian approach allowed to reach which system? All answers are right. And then the first trepanation during the carotenomy should be done at the K-hole is the correct question to 64%. Good number. And about the vessel flow assessment during bypass, what is the on flow choices? Angiographic patency does not equate with flow is true. Vessel diameter equates with flow. No, is false. Velocity does not equate with flow. It's true. Force does not equate with flow. True. And occulted with stick pulsate is true. So, what are the main complications of the retrosogmoid approach? We have Professor Ais bin Ali. What are the correct answers, Professor?
Yes, all these propositions: cranial nerves injury, vascular injury, cerebellar and hydrocephalus or infection.
Great. So, and a second question concerning the retrosigmoid approach, what are the structures at risk? The correct answers, Professor?
All these structures are at risk.
So you should be pay attention to vessels, brainstem, and cerebellum also.
Yes.
So what are the landmarks of middle fossa abdomen? Professor Talbush, what are the correct questions? The correct answers? Excuse me, there is some noise here.
Yes, c'est bon.
So all of that are correct. Not just the internal auditory canal, which is not correct because it's the middle mark and not the landmarks. So thank you so much for participating in this first part, and see you tomorrow. And Professor Ais bin Ali and all faculty are welcome if you can join us tomorrow. Bye bye. Good night.
Au revoir.
Au revoir.
Ouais.
Au revoir. Salam alaikum.
Merci.